Good afternoon, everyone. Let's begin with our last session for today. And I would like to introduce Dr. Piper. You already have heard about him because he led the last session. He's the clinical scientist. Okay. And he's a professor in the University of Toronto and also a doctor from St. Michael's Hospital. And he's very knowledgeable. If you go to Partner, you will see continuous publications from him. He's constantly writing, and he has a research program that has been internationally recognized. And it's focused in the use of randomized controlled trials with new focus and new methodologies, just as he showed in his last keynote. He also has policies that have to do with general diet and the prevention of cardiometabolic diseases. He's a lead in the University of Toronto. He has written several papers and received numerous awards. He's involved in the development of clinical practice guidelines for obesity, diabetes, and cardiovascular disease. And he is also part of expert committees in Canada and Europe. He has written over 300 papers and was recognized as a highly cited researcher in 2023 and 2024. And therefore, he is among the 0.1% of most cited researchers. Dr. Sievenpiper, the floor is yours. Please go ahead.
Thank you, Angel, and thanks again to FINUT and to ISA. It's really been a terrific day, and I'm really looking forward to this session. So it's my pleasure to introduce the session, to moderate this session on LNCS health effects, potential risks and benefits, new evidence from clinical studies. I think this builds really nicely off the last session, where one of the things we talked about was that need for really pivotal trials, really that have the power on their own to go beyond the meta-analyses to be able to answer some of these big questions, because the trials still are important. And one of the things that came out of the WHO report was the need for longer-term trials. That was the reason that one of the reasons they cited for overruling the randomized controlled trials was that they were too short-term. So we're going to hear about long-term trials from Jason, really some of the pivotal projects, the Sweet Tooth trial, our own Stop Sugars Now trial, which will be presented by my former PhD student, Sabrina, and then a number of other packages from the EU Sweet project and some other clinical trials. So I think a really important session going forward. So with that, I want to introduce our first speaker. So our first speaker is, I think I've already messed up the order. My apologies, is Lissette. So let me get to you, Lissette. The first speaker is Lissette Duarte Silva. She is a nutritionist and academic in the Department of Nutrition in the Faculty of Medicine, University of Chile. She holds a master's degree in nutrition from the University of Chile and a PhD in nutrition and food science with training in pediatric clinical nutrition and university pedagogy. She's an assistant professor in the Department of Nutrition in the University of Chile and a nutritionist in the Endocrine Medical Center of Clinical Santa Maria. Over 15 years of clinical experience in type 1 diabetes, and that's one of the things she'll be talking about, obesity and food allergies. She's led projects funded by national international institutions and has more than 20 scientific publications. She's president of the Scientific Committee of Chilean Society of Diabetes and director of the Chilean Society of Nutrition. Lissette, the floor is yours.
Hola a todos. Primero, muchas gracias por la invitación.
Hello, everyone. Thank you for having me here today. I will show the results of a research that we made in the University of Chile together with the Santa Maria Clinic. As Dr. Sievenpiper was saying, I work in both institutions, And the idea was to assess what was happening with the glycemic postprandial response and in the feeling of appetite for subjects diabetes with type 1, and there is not much research about this. So I will show what this work was about. I have no conflict of interest, at least nothing that I know of. Diabetes type 1 is a chronic disease, autoimmune, and there is insulinopenia and a need to have exogenous insulin from the beginning of the disease, unlike diabetes type 2. As we know, non-nutritive sweeteners are widely used for people that suffer from diabetes type 1 and type 2, and the recommendation has been valid. In the graph on the right, I would like to show you the consumption of sweeteners in the population that I researched. So first we began with an exploration research to see the consumption of sweeteners, because you know what happened in Chile according to the addition of sweeteners after the Chilean law. And what we saw is that all of this population, there were 33 people, we see the proportion of each of the sweeteners they consumed. Besides this, we have an analysis to see if they surpass the admissible ingestion, and we've seen that no, they did not surpass these limits, and they were intake that was variable according to the sweetener they had. Also, we have another analysis about the products the sweeteners came from and the proportion that was present. Something that was interesting is that most of them come from beverages, for example, soda, juices, etc. There are some other products that have them, like dairy, cereals, and other snacks. Something else that is important within the background is in the postprandial glycemia has an influence from different factors, not only because of the carbohydrates that are taken, and this is very easy to explain with the diabetes type 1 people, but they are calculated according to the carbohydrates, but the results are not always positive because there are many factors that are important, like the glycemic, the need of insulin of the person, and what the patient took with these hydrates. Also, their body composition is very interesting. As I was telling you, there is a very few evidence regarding the effects of sweeteners together with food and the effects on glycemia and also their appetite. And just to go through the research, I would like to mention this. It's in preclinic research and in cell research, we've seen that sweeteners can have an influence in glycemic indexes, but and this is explained by sweet receptors, which are the ones that we see here, T1, R2, and R3. These are sweetness sensors that are in the intestine cells. These are cells that are L and K, and they increase translocation of GLUT2 that are dependent of insulin, and they increase the absorption of glucose. This is what the theory
Bueno, entonces los
says.
objetivos de esta investigación fueron comparar los efectos de dos desayunos, uno que
So
contenía
we'll compare the effect
edulcorantes y
of
otro que no,
breakfast
sobre la
with
glicemia
and
postprandial
without
y también sobre la sensación de
sweeteners
apetito y
and
saciedad en adultos que tenían
the
diabetes tipo
effect in
1.
postprandial
Dentro de los
glycemia
objetivos,
and
por
the
supuesto,
feeling
medir
of
esta respuesta glicémica y
appetite.
también evaluar la sensación de apetito y
And we
saciedad
also need to
subjetiva. Era a
measure
través
the
de una encuesta o una
subjective
escala
feeling of
visométrica.
appetite, which was
La
made with a
metodología
visual
fue un ensayo
aid. The
clínico que fue
methodology
cruzado,
was a
aleatorizado y
clinical
controlado. Fue
trial
ciego
that
para los
was
participantes, no para
randomized
los
and controlled. It was
investigadores.
blind
Nosotros sabíamos
for
que le poníamos
persons,
acá en
but
el cursor.
not for
Y lo que
the
se hizo fue probar
investigators.
dos
And
desayunos.
we
Un
tried two
desayuno
different
que
breakfasts.
era equivalente
One
en cantidad de
was
hidratos de carbono y
equivalent in
equivalente en tipo de
carbohydrates,
productos.
and
La única
other in the
diferencia que
type of
tenía con el
products.
que
But
sí
the
contenía
only
edulcorantes
difference
era
with
la
the
adición de
sweeteners
edulcorantes
is
en estas dosis que están
additioning
mencionadas acá, que son 70
sweeteners here,
miligramos en el
which were
caso
70
de la
milligrams.
stevia, si bien, sí, veo bien, creo que no,
I don't know if
y
I'm seeing
30 en el caso de
correctly.
la sucralosa, ¿ya?
I think it
Y
was
usamos esta
36
dosis
from
porque es una
stevia
de las
and
dosis que más
34
se ha
from sucralose,
utilizado,
because this is one of the
que de alguna manera
most common
busca
doses we
asimilarse
see
a lo
that
que
try
aporta una
to
bebida gaseosa en
be
una
similar to
unidad de
what
plata,
the
¿ya?
unit of a soda
Y lo que
provides.
se hizo fue en 2 días separados por
We
7
had
días
two
dar el
different
desayuno que tenía
days
edulcorantes, medir la
where
glicemia
we
postprandial
had
y la sensación de apetito y
we
saciedad.
provided
Y
this breakfast
luego,
that included
7 días
sweeteners,
después,
and
volver a
we
medirla.
assessed
Y luego, en 7
the
días después,
postprandial
medirla por
glycemia,
control.
and we did
El orden en
after
que
that,
sucedieron estas
after
cosas fue
7 days, we
aleatorizado.
did it.
Por ejemplo,
And
algunos
this was
partieron con el alimento
randomized.
control, que era solo pan blanco. Otro grupo partió
Some
con el
patients
desayuno con
started
edulcorantes y
with
otro grupo
white
partió con el
bread,
desayuno
others
sin
with
edulcorantes, ¿ya?
sweeteners, and
Y
others
esto se
without sweeteners.
aleatorizó,
And
fue
this
al azar,
was
en
randomized.
efecto. Y algo interesante que hicimos
Something
también fue
interesting
utilizar
that we
sensores de
did is
glucosa,
to
estos
use
sensores que se
glucose
ponen en la
sensors,
piel,
the
que miden
ones
la
that you have
glicemia
in your
intersticial, para poder
skin,
asegurarnos de
to make
que no hubiera
sure
ningún descontrol, porque estas
that
personas,
there was no
por ejemplo, podían irse a hipoglicemia o hiperglicemia por
unbalance
nuestra culpa, entonces el
in
comité
our
de ética de alguna
patients.
manera nos exigió que usaran alguna medida
The
de
ethics
control, ¿ya?
committee demanded that we do that.
Bueno, aquí yo les muestro cómo es la distribución de
Here
esos
I would like
desayunos
to
en
show
aporte de
you the
energía, proteínas y
distribution
carbohidratos. Si se fijan,
in
son
protein,
iguales en
carbohydrates,
cantidad de carbohidratos.
energy, and we
Obviamente, la
see that
cantidad de
they are all
carbohidratos
the
que
same
incluye
in
el alimento
terms of
control era solo
carbohydrates,
pan
and the
blanco.
energy is
Y
different
la
because
cantidad de
in the control
stevia
we
y
have only white
sucralosa es
bread, and the amount of
diferente en el
stevia and
desayuno que tenía
sucralose
edulcorantes
is
versus el que
different
no.
in the one
Ahí
that has
también se ve cómo
sweeteners
era
and the
ese
one that doesn't
desayuno.
have it. And here
Y
you
como
can
les digo,
see the
nosotros les
picture
entregábamos
of
los
this
desayunos porque esto
breakfast.
sucedió en
We gave
pandemia,
them the
a
breakfast.
ojos
This
de la
happened
pandemia.
during the
Íbamos a su
pandemic.
casa,
So we went
entregábamos
to
el
their homes,
desayuno, se
we
tomara el
delivered the
desayuno.
breakfast,
Y en
and then we
algunos
came
casos
back.
también hacíamos monitoreo a
And
distancia
sometimes
de las
we
glicemias, porque
did
ellos tienen glucómetros, las personas con
online
diabetes tipo 1. Aquí
online
están las
follow-ups
características
because
de los
they have a
participantes,
way
eran
to
todos
measure their
adultos. Aquí tenemos
glucose.
los
We
índices
have all
glicémicos de
adults,
medición
we have weight.
por el índice de masa corporal, o sea,
There
habían
was no
personas que tenían
distinction
estado
according to
nutricional
their
normal, sobrepeso, obesidad,
BMI.
tenían diabetes la mayoría hace bastante
Most of
años,
them
¿ya? Eran personas que
had
eran bien
suffered from
exigentes en conteo de
diabetes in a
carbohidratos, tenían un
long
control
for a
metabólico
long time,
bastante
so they
alto,
were
o sea, su hemoglobina
experts
glucosilada era de
in
7,
measuring
7,5, que
carbohydrates,
es lo que
and
actualmente se recomienda.
their
Y
HbA1c
por
was
otra parte,
around was
había un
very
porcentaje de ellos que usábamos la
stable.
insulina
And
y
some
otro
of them
porcentaje que
used an
usábamos
insulin
IOSI,
pump
esta es
and
inyección.
some others injections.
¿Qué es lo que observamos? Y uno de los
What we
resultados que
saw
nos
and
llamó
one
la
of the
atención
changes
fue
that were
que sí hubieron
most
algunas
interesting
diferencias en las
is
glicemias
that there were
postprandiales
some
más
differences
tempranas en el
postprandial
desayuno que
indexes in the
contenía
beginning
edulcorantes
in
versus el que no.
breakfast
Si
that
ustedes se
have
fijan, yo les
sweeteners and
pongo
the
acá
one that
con
doesn't. Here
asterisco
you can see the graph and you can
que al
see
menos a los 15 y los
at
30
15
minutos sí hubo
and
diferencias,
30
¿ya?
minutes there were
Y
some
obviamente
differences,
esto también se observó versus el alimento control que era el pan, ¿ya?
and compared to control, which
También
was
es
breath.
importante señalar
Also,
que
it is
en el
important to
postprandial más
highlight
tardío,
that
que
in the
son los 120
postprandial,
minutos
which
después, a
was
estas personas se les recomienda
120
medir la
minutes,
glicemia,
where
aquellos que no
they
tienen
need
sensor
to
desconocer lo que
measure
pasa
their
entre medio.
glycemia.
Con ambos desayunos se llegó a una
With both
glicemia que es
breakfasts,
adecuada,
they
¿ya? Es
had
considerada normal. Está marcado ahí
normal
con un cuadrito
glycemia. You
verde
can
lo que
see
se
it
considera
here.
adecuado, ¿ya? Adecuado para el postprandial.
Green
Entonces,
level for
más
postprandial is
tempranamente
in
subimos la
green.
glicemia con el
So
desayuno con
later on,
edulcorantes, pero a largo plazo se llegó
so
a
in the
una
beginning,
glicemia
we
que se
did see
considera
that
normal
glycemia
con
was
los 3
higher
desayunos.
with NSS, but with NNS, but
Y
then it
luego
was
al
the same same level after
allá abajo la
120
curva
minutes.
incremental y el índice glicémico glicémico se observó que
Then
en verdad no
we
había
have the
diferencias en
glycemic index, and
según
we
los dos
see no
desayunos.
difference
Obviamente respecto al control sí es diferente porque
compared to control. Of
básicamente
course,
era como
this was
patrón.
different.
Y el área bajo la curva tampoco fue diferente, ¿ya?
And we had no
Luego, al
relevance in
analizar
these. When we
cómo fue
analyzed
las diferencias en la sensación o percepción de
the
apetito, sí
appetite
encontramos
score,
que en
we
comparación
did
con el
find that
control, el
compared
desayuno que
to
contenía
control, the
edulcorantes
breakfast that
presentó un
had
aumento
sweeteners
en la puntuación de
showed an
apetito solo a los
increase
60
in the
minutos, pero a la
appetite
larga
after 60
luego
minutes,
se
but in the longer
fue
term,
idénte
it
al
was the
desayuno que no
same
contenía edulcorantes.
compared to no
Entonces,
NNS.
como conclusión, en estos adultos
So to wrap
quedaron
up, for
23 adultos que
patients, we
tenían
had
diabetes tipo 1,
23
tanto
patients
el
with
desayuno con como sin
diabetes type
edulcorante
1,
presentaron índices
breakfast
glicémicos que eran
with and
comparables.
without
Esto era algo esperable porque estaban
sweeteners.
compuestos por
They
los mismos
presented
alimentos que los
glycemic
calculábamos
indexes
nosotros y
that were
nombrábamos nosotros. Los
comparable.
desayunos que contenían
Breakfast that
edulcorantes sí tuvieron
included
una glicemia postprandial
sweeteners
temprana más
had
elevada
earlier
que superó la
postprandial
recomendación de
glycemia that
litro de
was
sodio
higher
mol por litro
and
a
went
180 miligramos por
over the
decilitro,
recommendation.
pero
It
esto fue
was
a los
surpassed,
15
but
y
this
30
only
minutos,
happened
no
at
en
the
los
15 and
120 que
30
esperábamos,
minutes. But
donde se hacen el control las
after
personas que tenían diabetes 1 o
120
2.
minutes, it was
Pero
similar.
también los desayunos que
And
contenían
finally,
edulcorantes
breakfast
provocaron un
that
aumento
included
transitorio del
sweeteners
apetito a los 60 minutos en
provoked a
comparación con el control, pero
transitory
esto no se
increase of
preservó a la
appetite
largo plazo.
after 60 minutes,
Ahora,
but not
¿cuáles
in the
son
long
las
term.
investigaciones futuras que
What are
deberían
the needs of
haber para
future
algunos de estos
research
resultados?
that we need to have
Probablemente
after
es necesario
this
todavía evaluar
review?
cuáles son los
We need
mecanismos
to assess
fisiológicos
which are the
subyacentes a este aumento de la
physiological
glicemia y
mechanisms
también del apetito que son más bien
underlying the
tempranos,
early
¿ya?
increase of
Y también es
glycemia
necesario
and the
explorar cuáles son los efectos
appetite
del uso
induced,
crónico, porque
and
nosotros
also
sabemos
the
que
effects
la
of
glicemia que
chronic
esté más
use,
alta
because we
quizás
know
los
that
primeros 30
having
minutos y un poco más
glycemia
alta,
that it is
va a tener un
higher
efecto
in the first
clínico,
30
eso no lo
minutes,
sé. Yo solo sé que
and
subió y
I
que
don't know
subió
if it will have a
¿ya?
clinical effect.
Por
I don't know
último,
that. I
bueno,
only know
destacar
that it
que
was
este estudio
increased
fue
for the
realizado
first
gracias a un
30 minutes,
financiamiento
and
un poco
then
con fondos
after
responsable, que ahí
120,
sale
it
el nombre
was
del código,
regular. Here we
y
have the
también fueron
funding
resultados en los ensayos clínicos, y ahí sale el código
and the
también, y
clinical
esperamos
trials were
publicarlo pronto.
presented. We have the codes, and
Eso,
we
muchas
will
gracias
publish this
por su
very
atención.
soon. Thank you very much.
Thank you very much. We're going to move on to the next talk, which is the effect of LNCS on gut microbiota and postprandial GLP-1, which is going to be delivered by Alonso Romo-Romo. Alonso is a nutritionist from the Universidad de Valle de Mexico and diabetes educator certified by the Mexican Diabetes Federation with a specialty in clinical and public health nutrition from the University of Barcelona. He holds a master's in clinical epidemiology and a PhD in sciences from the National Autonomous University of Mexico. He is a level 1 researcher in the National System of Researchers and was research coordinator in nutrition at the Department of Endocrinology and Lipid Metabolism of the Institut Nacional de looks like Nutrición Salvador Zuberian. Hopefully I'm not butchering that. My apologies. He is currently full research professor in the Department of Nutrition at the University Autónoma de this is going to be a tough one. Aguascaliente? Yeah, okay. He has presented at over 75 national and international conferences, authored 23 scientific articles, 11 book chapters, and the book Nutrition and COVID-19. The floor is yours.
Buenas tardes.
Hi, good
Antes que nada,
afternoon.
pues es un gusto la invitación y estar
First of
estos
all,
2
thank
minutos
you
aquí
for
compartiendo con
having
ustedes.
me here
Yo
today.
les voy a presentar un poquito de evidencia diferente a lo que se ha
I will
mostrado hasta el día
show
de hoy.
some different evidence from what
Un
we've
poquito
seen
el
so
otro
far.
lado de
I will show
otra cara de
you
la
the
moneda
other side
y basada
of
principalmente
things
justo no
based
en estudios
mainly
observacionales, sino en
not
estudios
in
clínicos.
observational studies,
Entonces,
but
no tengo ningún conflicto
on
de interés
clinical
relacionado con esta
trials.
ponencia.
I have no disclaimers to make.
Y les voy a presentar primero un estudio que
And first of all,
hicimos
I would
en
like
el
to
Instituto
show a
Nacional Clínico
research.
Aleatorizado
We
Halford
had a
investigo, también
randomized
registrado en Clinical Trials,
triple-blinded
que incluyó
study
una población de 40
that
personas,
included 40
adultos sanos,
subjects,
normopeso,
healthy,
jóvenes, que habitualmente no
healthy
consumían
weight
edulcorantes no
that
nutritivos
did
y
not
que tampoco tuvieran resistencia a
consume
la insulina.
sweeteners
La
and without
intervención consistió
insulin
en el
resistance. The
30% de la
intervention was
ingesta diaria admisible de
30%
sucralosa establecida
of the
por el JECFA
AGI
y la
established
intervención se
by
dio a través de
JECFA,
cápsulas que
and
contenían
we
sucralosa
had
pura
capsules that
y el
include
grupo
pure
control recibió
sucralose, and
cápsulas
the
de
control
placebo.
group had
El
placebo
seguimiento fue a
capsules,
30
and the
días.
follow-up happened
Lo que
after
hicimos,
30
el estudio
days.
tuvo varios brazos,
So
pero
we
uno de
had
ellos fue
different
el hacer unas
arms in this
curvas con
study,
una
but we
comida
created
mixta
some
para evaluar
curves
secreción
with a
postprandial de
mixed
diferentes
to
hormonas y ver la respuesta
assess
glucémica y
the
también, bueno, la
suppression,
parte de la microbiota intestinal.
postprandial
Entonces
secretion,
aquí se
and the
muestra
microbiota.
la parte de la respuesta
Here we can
postprandial.
see the
Vemos cómo
postprandial
con el consumo
response,
de
and we can
sucralosa al
see with the
final de la
consumption
intervención
of
hubo mayor
sucralose,
respuesta
there
en los
was a
fosfatos
higher
glucémicos
response in
y
the
también mayor
glucose
secreción de
response
insulina
and
en el
more
grupo de sucralosa.
insulin
Y bueno, fue
secretion in this
estadísticamente
group. It
significativo
was
el incremento
statistically
en el área bajo la
significant
curva
where we
incremental
see the
de glucosa e
baseline
insulina. También hubo
in
un
glucose
aumento
and
significativo
insulin.
del valor de
Also, we
HOMA-IR
saw
y una reducción
a
del índice de
significant increase
Matsuda
in the
en el
value
grupo
of
de
HOMA
sucralosa, una reducción del
and
23%
Matsuda,
en
a
el índice de
reduction of
Matsuda.
23%
También en
in
cuanto a la
Matsuda
secreción de
index.
GLP-1,
When we
pues vean
talk
aquí la
about
curva
the
del grupo de
concentration of
sucralosa mostró
GLP-1
también
with the
mayores
sucralose
concentraciones al
group
final de la
showed
intervención
higher
y bueno, también un
concentrations in the
incremento
end
en
of
el área bajo curva
intervention
incremental.
and also
En
an
cuanto a la microbiota
increase.
intestinal,
When we talk about the
hubo una reducción
microbiota, there
significativa en
was
el índice de Shannon en
significant
el grupo
reduction in the
sucralosa,
Shannon index
que
for
nos
the
habla, por
sucralose
supuesto, de
group
la
that talks
transversalidad
about
de
the
esta,
high
cómo hay una
diversity,
heterogeneidad en la comunidad
and
bacteriana, cómo se
we can
distribuye,
see
y pues no hubo un
heterogeneity
cambio
in
significativo en
the
el grupo
bacteria
control.
and the
En cuanto
microbiota and no
al
changes
análisis de
in the control group.
metadiversidad con análisis
When
de
we see the
coordenadas principales,
metadiversity,
que también habla de
the
similitud y
PCOA,
diferencia entre las
we talk
comunidades
about
bacterianas, pues vean cómo en el
baseline
grupo placebo
placebo and
no hubo una
sucralose. In the
diferencia
placebo, we
significativa
did
con el
not
estado
see
basal, pero sí hubo mucha
significant
más
difference,
variabilidad
but
en el
there
grupo
was
de
a lot of
sucralosa en la
variables in
medición
the
final.
sucralose
En
group.
cuanto a ya composición de
When
bacterias,
we
hubo
talk
cambios en
about
diferentes
bacteria, we
géneros,
saw
géneros y
different
especies de bacterias.
changes in phylum and
Caliumefilum, que sabemos
genus.
que no
When we
tiene
talk
tanta
about
interpretación
phylum that
clínica, pues
has
sí
not
hubo un
many
incremento de
clinical
bacteroidetes, que son
interpretation,
bacterias
we saw an
gram-negativas, y una
increase
disminución
in
pequeña de
bacteria deaths
firmicutes.
and a
Pero ya
decrease in
yéndonos a
firmicutes.
nivel de
But
género,
when we talk
aumentó, por
about
ejemplo,
genus, we
bacteroides y
can see an
alister, que
increase in
también en
bacteroids,
exceso
the
se asocia
alister,
como un
that
poquito a
in an
distensión lunar
excess of it
abdominal. Hubo
talks
aumento de
about
Escherichia, disminución de
abdominal
Prevotella,
extension. We saw
disminución de
Escherichia,
ruminococcus y disminución de
decrease of
Faecalibacterium.
Prevotella,
Ya
Ruminococcus,
haciendo el
and
análisis discriminante
Faecalibacterium.
lineal para
When we
ver cuáles
have
bacterias fueron
this
las que se modificaron
analysis
significativamente
to
con la
see which
intervención,
were
pues hubo un aumento de
significantly
Bacteroides
modified,
fragilis.
we have an
Ahorita vamos a
increase
hablar
of
de las bacterias
Bacteroides
gram-negativas que
fragilis,
contienen lipopolisacárido
and we will
y
go
una
further
disminución de
into
Ruminococcus
this,
brommi,
and
que
a
es una
decrease
bacteria
in
importante para
Ruminococcus
la
brommi, which
fermentación
is
de
very
almiones
important for
resistentes,
fermentation
y
of
una disminución de
resistant,
Faecalibacterium prausnitzii,
for
que se
the
ha asociado
resisting, and
con
a
una
decrease of
mejor tolerancia a la
Faecalibacterium
glucosa, a
paradoxin,
efectos
which is
antiinflamatorios.
related with
En cuanto a los SSBs de
anti-inflammatory
cadena corta, se
effects.
observa
When
un
we talk
incremento del
about
acetato que
AGCC,
se relaciona con aumento de la lipogénesis y una disminución
we
del
have an increase
butirato
of
que
acids,
también
and
nos habla
butyrate
de pues
talks
esa
about
integridad de
the
la barrera
integrity
intestinal.
of the
Se midieron diferentes
intestinal
marcadores
wall. We
inflamatorios y
measured
hubo un aumento
several
bastante considerable,
pro-inflammatory
muy
markers,
marcado,
and
como
we
lo
have
pueden ver
a
aquí, de la
high
concentración de
increase in the
lipopolisacárido en los que consumieron
concentration
la
of
sucralosa. También hubo un aumento
lipopolysaccharides.
más pequeño del valor de TNF-alfa y de la interleucina 6.
Also, we have an
Y
increase
bueno,
of
aunado
alpha.
también en este
Also,
protocolo,
if we
no
see
dentro de
this,
esa publicación, pero
not
también
within this
medimos la sensibilidad
publication,
a la
we also
insulina a
measure
través del
sensibility
estándar
of
de oro para
insulin
este
with the
desenlace, que es
gold
el clam
standard, which
hipoglucémico
is CLAM,
hiperinsulinúrico, y lo
in
hicimos a dosis bajas y
glucemia, and
dosis
we do it
altas
in
para poder
lower and
diferenciar
higher
a nivel
doses to
hepático y
be
a nivel
able
musculoesquelético.
to
Y
make a difference
hubo una
between the
reducción del
liver
valor de
and
M sobre I, que nos habla de la tasa
muscle and skeletal
de dosificación de
levels. So
glucosa.
we talk
Hubo
about the
una disminución
dosification
en el grupo de
of
sucralosa,
glycemia, and we
tanto a
had a
nivel de
difference in
hígado como de músculo
sucralose
esquelético, ya
both
sea
in the
ajustado por
liver,
peso corporal
in the
total o
model
masa libre de
adjusted
grasa
per
adherida con DEXA.
kilogram or
Entonces,
per
nos habla
mass with
precisamente pues
DEXA.
una disminución
So this
significativa de
is
la
a
sensibilidad
significant
a la insulina.
reduction
Y
of
bueno,
insulin
no solamente es
sensibility.
nuestro estudio, hay
And this is not
varios estudios que se han
only,
hecho y que han
this was not
reportado
only our study, but
resistencia a
there
la
are
insulina
several
en
that
consumo
have
de los edulcorantes, ensayos
shown
clínicos, solamente uno
insulin resistance due to sweeteners. One of them is from acute exposition, and the others are only follow-ups to 4, 6, 10 weeks. In the 2000s, we had acute exposition, but not repeated exposition to sweeteners. That's why the meta-analysis of insulin are not very significant, because if you have them only once, you will not see any difference. There are high mixes of methodologies that vary a lot in micrograms and milligrams, and the instruments to be able to measure them. No study had used GLAM before. We had a previous study that used IV testing, and there were no other research that had this. And we have associated mechanisms with non-nutritive sweeteners and the changes in the microbiota. In the previous keynote, we mentioned that sucralose has been related to more secretion of GLP-1, GIP in animals with the sweet receptors, because when we add germarin, which is an inhibitor of these receptors, we see a different effect. Also, an increase of SGLT1 through the sweet receptors, because in rats that did not express T1R3, we did not see the same effect. In other studies, we have seen more expression of GLUT2, which means that when we ingest a sweetener with carbohydrates, this increases passive and active transportation of glucose. So we can see more exposition of sucralose, more absorption of glucose. Those other mechanisms in the microbiota are related to the abundance of pathogenic bacteria, the abundance of beneficial bacteria, the alteration of SCFAs, and in other studies in animals, we've seen the increase of the gut pH. Also, when we talk about gram-negative bacteria that are in the external membrane, like the lipopolysaccharide, that is an endotoxin in our body, and that acts with the TOL4 receptors and the macrophages, increasing the inflammatory cytokines, which has several effects in our body. But one of the most important that affects insulin is pro-inflammatory cytokines that generate insulin resistance. This is another study. This was very controversial in 2014. It had different phases in animals, and there was only a small study with 7 people and have 100% of ADI with saccharin for 7 days, and it found that 4 out of 7 participants showed a higher glycemic response with the ingestion of saccharin. And in the microbiota, it saw an increase of clostridiols and bacteroids. And this created feces in the responsive and non-responsive rats that had not ingested the sweeteners. And when they received the feces, they had higher response in the glycemic index. Of course, these were not the only researchers about microbiome. We have seen many, most of them are in animals. Maybe like 3 clinical trials have reported changes in microbiota in healthy adults. And when we talk about GLP-1, this has been shown in several clinical trials that sometimes they can say, well, it might be beneficial because more GLP-1 for a diabetes patient. Well, patients with diabetes type 2, there is no effect in the secretion of GLP-1. We can see that in healthy patients and patients with diabetes type 1, with the doses of 46 milligrams of sucralose. In this other trial, in diabetes type 2
Se
and
observa que
healthy
el EP1 en
patients,
los pacientes sanos
the
con una dosis de
GLP-1 only
24
increased
miligramos
on
de sucralosa.
healthy patients with
Finalmente,
a
este
dosage
estudio
of
que ya fue 4
0.1.
semanas con
And we
una
had
dosis
a
de 200
4-week
miligramos
study
de
with a
sucralosa al
dosage of
día,
200
también hubo
milligrams of
mayor área
sucralose. We
bajo la
saw
curva de secreción de GLP-1
our
y se observó
expression
igual
of
disminución
GLP-1
de
and
Matsuda del
decrease of
HOMA-S y un
Matsuda,
aumento del
HOMA-S, and
HOMA-IR.
HOMA-I.
Y bueno, ya para cerrar,
And
justo
to wrap up,
estas guías de la OMS, ¿no? que fueron tan
the
comentadas
guidelines
y que
from
fui
the
parte del grupo
WHO,
de revisores
I
externos
was
de
part of
estas
the
guías,
external
pues precisamente
reviewers
esta
and
recomendación que
of
se
these
menciona,
guides. We have this
esta
recommendation
recomendación condicional, ¿no? que estamos platicando,
that we
y
have
que
been
menciona no
talking
toma en
about, and it
cuenta
says
los ensayos clínicos, sino nada más
didn't
los
take into
estudios
account the
observacionales,
clinical
¿no? Sí los
trials,
toma
but
en cuenta,
only
pero justo como
observational
son
studies.
pocos
It
estudios
was
controlados que han
they were
reportado,
taken into
pues
account, but
justo
they were
queremos
only a
esa
few clinical
precaución,
trials. So they want
pues
to
no hacer
make
una
this
recomendación
disclaimer and
personal
avoid
con
having a
sueros,
recommendation saying
libremente,
that
¿no?
we can
Y
freely
precisamente
consume sweeteners.
mis conclusiones serían que algunos
The
edulcorantes, porque
conclusions
es
are that
importante
some
mencionar lo que no podemos generalizarlo a todas las sustancias, tenemos que
LNCS we
separar
cannot
los efectos por
generalize.
cada
We
uno de
need
los
to
edulcorantes.
split
En
for
microbiota
each of the
principalmente se han
sweeteners,
encontrado
especially when we
experimentos de
talk about the
sucralosa,
microbiota. We
desacaridina y
have studies
stevia,
about
porque
sucralose,
son los que
stevia,
podrían tener
and
más interacción
saccharin
a nivel
because they might
colónico,
have
pero
more
hay
interaction
mucha
in the
mayor
gut.
evidencia
But
con
if
la
you see,
sucralosa.
we have
Entonces, sí
more
podrían modificar la
interaction with
composición y la
sucralose. These
microbiota
might
intestinal y estimular la
modify
secreción de GLP-1. Lo que tenemos que
the
reconocer es que hay
microbiota, and
resultados
we
muy
need to
diversos en cuanto a las
accept that
poblaciones
there are
incluidas,
diverse results
las
according to
interacciones
the
de dosis, forma de
population, the
administración, la
interventions,
temporalidad
process,
y las metodologías a
the
cómo se ha
timing and
medido esa
methodologies,
sensibilidad a
how
la
this
insulina en los pacientes.
insulin sensibility
Obviamente,
was
ya vieron que son pocos estudios,
measured.
entonces no
You
se
can
puede
see
hacer
that
un
there
metaanálisis de
aren't
CLAMP, porque no hay un estudio de
many
CLAMP.
researchers
Entonces, este
because
tipo de
we
metodologías
are
aún
not
no hay
able
evidencia
to
para poder
create a
hacer un análisis en
meta-analysis
conjunto que nos pueda dar como una
that
conclusión.
can
Y
provide a
bueno, justo
conclusion.
mencionaban lo de que pues no son inertes en
And
nuestro
of
cuerpo,
course, they
no,
are not,
efectivamente va a tener un
they are
metabolismo,
part of
pero
our metabolism, but to be
reconocer
able to
que
acknowledge that
probablemente
there is
pueden tener
likelihood
diferentes
of
efectos
different
a nivel de
effects
metabolismo
in
de
our
glucosa, a nivel de composición
glucose
metabólica, pero hay que
metabolism and
investigar a
body
profundidad
composition.
cada
But we
uno de
need
los
to go
edulcorantes y
deeper
separar
into
los
each of
efectos
the
que podrían
sweeteners
tener.
and to be
Y bueno,
able
muchas gracias
to
por su atención.
specify the effects of each of them. Thank you very much.
Thank you very much. We're going to move on to the next talk. This is by Eva Almirón Roig. It's part of the EU SWEET project, effective acute and repeated LNCS consumption on appetite and metabolic outcomes. I'll just read quickly the bio for Eva. She holds a PhD in biological sciences from the University of East Anglia, a master's in nutrition from the University of Washington, and is a registered dietitian with the UK Health and Care Professionals Council. She has held academic teaching and clinical positions in several international institutions, including the Nestle Research Centre, the Medical Research Council, and the UK National Health Service. Since 2016, she's been a researcher at the Nutrition Research Centre at the University of Navarra, where she leads the Eating Habits and Food Behavior Group. She has over 20 years of research experience in obesity prevention, particularly in appetite and satiety regulation, portion control, eating rate, and behavioral assessment methods. She is currently the principal investigator of the Portions 5 and the Plenty food projects, and previously coordinated the eating behavior work package of the EU SWEET project. Eva, who will be joining us online? We're just waiting to get connected.
Buenas tardes. En primer lugar, quería agradecer al Comité
Good
Científico la
afternoon.
oportunidad
First of
de
all,
participar
thank
en
you
este congreso.
for the opportunity to participate. The title is The Effect of Acute and Repeated Low or Non-Caloric Sweeteners Consumption on Appetite and Metabolic Outcomes SWEET Project.
No tengo conflictos de interés relacionados con esta presentación.
No conflict of interest related to this
Los
presentation.
edulcorantes a los cuales me voy a referir
So the
como
enhancers I'm going
edulcorantes
to
en esta
refer to in
presentación
this presentation
se utilizan
are
habitualmente en
used
alimentos,
normally
bebidas y bebidas
in
por su
foods
potencial
and
para mejorar el
beverages
control de la
due to their
glucemia y
potential
ayudar
to
en el
control
control del peso.
glycemia and
En
improving
el ensayo
weight loss
controlado
control.
aleatorizado SWEET de un
In
año
the
de duración
controlled
y recientemente
assay
terminado, se
that
mostró que
occurred
cuando
for
se
an entire
consumen en
year, we
alimentos y
showed
con una
that when
dieta
they are
saludable
consumed in a
mantenida,
healthy
los
diet that is
edulcorantes
maintained,
ayudan en el mantenimiento del peso
these
objetivo.
NCSs
En
help
este
in the
ensayo
weight loss
se
control.
investigaron las
efforts. This analysis did not show the differences between different chemicals, but we definitely can tell that due to the chemical structure of most of them, they do show a form of effectiveness because these are mostly heterogeneous compounds. The impact of repeated exposure continues to be unknown yet. In the context of this knowledge, the sweet WP2 investigated the short-term impact on food behavior, physiology, and health, and in adult individuals that were overweight but healthy. The aim of this sweet WP2 was to evaluate the acute, short, and repeated effects of existing and or novel combinations on metabolic processes, sensory and neurobehavioral and microbiota-mediated processes, to examine also the mechanisms of processes, genetic background, safety issues, and consumer perspectives. But I would divide that into phases. The first one consisted of a coordinated trial of 3 sites in Spain, England, and Denmark. There was an exploration of the acute effects of 3 new mixtures of NCSs and one control in a beverage matrix. In phase 2, which consisted of a multi-center trial, 5 sites in the United Kingdom, in Spain and Denmark, we explored the short and medium-term effects of 2 standalone LNCSs and 2 blends selected in phase 1 versus sucrose control products in 5 solid and semi-solid food matrices. And I will focus on the effect of beverages and the effects of isolated LNCSs in the dietary matrix. In phase 1 study, which was for beverages, we had the participation of 51 adult volunteers that were healthy but overweight, were recruited in 3 universities of Spain, the United Kingdom, and Denmark. All of the volunteers would drink a beverage once a week with, we would include saccharose or maybe a mixture of LNCSs. The beverage was administered in a format of 230 milliliters, and we analyzed the glycemic response, blood biochemistry, feeding behavior, and consumer perspectives. Of this phase, we selected 2 blends to be selected for phase 2. The ones that were chosen were of vegetable origin like stevia and hemogracid 5, or monk fruit, and stevia 2, which is a sweet protein, all of them that are plant-based, or selected sucralose that is mostly used in several commercial beverages. In the case of a control beverage, we included 26 grams of sugar that would provide 106 calories, while the other beverages would provide no calories. The volunteers followed the same procedure for 4 months in a randomized order, and every time they would go to the lab, they followed the same procedures in all of the centers. The only thing that was different was the exact composition of the breakfast, as we can see here on the right, which was different regarding the countries so that they could adapt to the gastronomic and cultural aspects. And in this case, the sugar provided 440 calories for women and 600 for men. The volunteers did not eat anything before breakfast, would be taken blood work with them, and then after the fact, they would be given breakfast and they would show the responses in an electronic format. They would also prove the 330 milliliters that they had to drink. They would be given a questionnaire, and then once again, the blood work would be taken a second time after consumption of breakfast. Then they would also go into a second questionnaire in which they would respond questions regarding preferences, and after 2 hours, a third blood work would be taken for them. After 2 hours of that last questionnaire would be taken, they would be given water, and we would register their sensations of whether they would experience cravings or other forms of hunger. We also administered tests for the gut health. And the main results that we have in the subjective aspect show that the blends do not differ significantly in their behavior
frente a la sacarosa,
sensations
sobre todo no
or
se vio
hunger
efecto del hambre
against
rebote y
sucrose.
solamente se vieron pequeños efectos
Using
por
this higher
algunas de las
subjective
mezclas
perspective
en la
intake, the
digesta
desire to
positiva
eat
y la
readings
SSB.
versus
Sin embargo, estas diferencias fueron de magnitud
however,
mínima,
these
como se puede
differences were
apreciar en
tended to
la
be
gráfica,
not
y no se
particularly
trasladaron en
significant,
ninguna
and
manera en cambios en la conducta
they did
durante
not
los días
translate in
24 horas. De
changes
hecho, no hubo diferencias
of
en la ingesta de
behavior
azúcar
of
en
hunger
ese
after 24 hours, which was measured
En cuanto a la
the
respuesta
time. Now,
glucémica,
regarding
las
glycemic
múltiples mezclas se
response,
comportaron de forma muy
the
similar entre
blends
ellas y distintas a la
behaved
sacarosa.
quite
Así,
similarly
no se
amongst
indujeron
themselves,
la
but very
respuesta
different to sucrose.
insulinémica de forma significativa tras el
Reduced insulin
desayuno y
response with all
también
blends
redujeron
versus
la
sucrose. Some
cantidad de
evidence
glucosa
of
en
reduced
sangre,
glucose
aunque
response
esta
with
no
some
fue
blends of versus
significativamente
sucrose.
distinta de la
And although
sacarosa,
they did
en
not
el
show
tipo
a
de monoxidil
significant
con
difference,
stevia RPM. Esta
that we also
combinación en la
included
respuesta de
stevia
la
into the
glucosa
mix.
podía
The
deberse
response
a
of
que la
glucose might
carga de
actually happen
carbohidratos del
because the
desayuno
charge
era
of
de
carbs
50 a 80 gramos,
in
lo
the
que podía
breakfast
haber
was about 80 grams, which
atenuado un
could
poco la
have
respuesta de las
maybe
mujeres frente a
mitigated the
las
response
veces
of
de la
the
glucosa en
blends
sangre.
themselves
Sin
on the
embargo, la respuesta
glucose and
insulinémica
blood.
sí que fue
However, the
muy
insulinemic
marcada.
response tended to be
De
quite
estos
pointed.
resultados se
Of
seleccionaron
these
dos mezclas
results,
para
we
pasar a la fase
selected two
2, que
blends
son
that
el
would go
monoxidil
into
con
phase 2,
stevia
which
RPM y la
was
sucralosa acesulfámica,
stevia,
pero que por cuestiones de
our
tiempo no puedo detallar en
EBM
esta presentación.
neotame that
Sí que
unfortunately
mencionaré
for
los
time
resultados
constraints I
del
cannot
estudio de
delve
la
deeper
primera
into, but I will
de
focus on the
estudios
first
del
wave of studies from
2021-2023 con
2021 to
edulcorantes
2023
aislados, que en este
with
caso fueron
isolated
la
sucrose,
stevia
which in
RPM
this
por
case
un
was
lado
stevia
y el
rebam
neotamo por
and
otro,
a
que se
neotame on the
vieron
other side,
administrados en
which were
forma de
administered
galletitas.
in format of
En los
cookies or
estudios de la fase
biscuits.
2
In phase 2
participaron 53
studies, we
voluntarios
had the
adultos con
participation of
sobrepeso y obesidad que
53
consumieron 3
volunteers
galletas,
had
que es lo que
obesity.
consistía
They
una
would eat
ración de
3
galletas,
biscuits or cookies
durante 15 días, una vez al
for
día de forma
15
repetida. Siguieron
days,
este
once a
consumo
day, in a
pasaron por
repeated
una fase de
fashion.
lavado de
And
15
we
días
went to
y
a
entraron en la
washing phase
segunda
of
fase de
15 days, and
consumo de
then they will go
galletas
into the
que
second phase
contenían otras de
of a
las
cookie
de los
consumption that
edulcorantes
would
del control
have
y
the
seguido de este periodo de
sucrose or
consumo
maybe the
repetido
control
otro periodo de lavado de 15 días
substance, and then they
tras
will
el
go into
cual
a yet another period
consumieron
of
la última
wash of
tanda de
15
galletas.
days
Es
in which
decir,
they would eat
el
a
estudio
third round of
consistió en
cookies.
3
That
tandas
means that the
separadas
study
por
comprised
2
three separate
semanas de
rounds
lavado cada una,
separated by 2 weeks
durante las cuales
of
se
a wash
consumieron
in which they
durante 15
consumed
días una
during
vez al
15
día las
days
3
once a day
galletas.
the 3
Estas
cookies.
de forma aleatoria
These
contenían
randomized in a
sacarosa
randomized trial would contain
y la
sucrose
ración proporcionaba 360
or
calorías
in
o bien
with a
el
caloric intake
neotamo
of
o bien
330
stevia M, que
calories
proporcionaban
or monk food
326 calorías en
stevia
ese caso.
or Reb
Las
stevia.
galletas, al igual que las bebidas, se
The
aparearon
cookies, like
tanto
the
por el sabor y
beverages,
aspecto físico como por
were
todo lo que es
similar
la
in their
carga y
physical
nutrientes. En
aspect
el caso
and
de
their
las galletas,
nutrient
se
charge.
sustituyó el azúcar
Because of the
por
cookies, we
edulcorante y para
substituted
mantener
sugar
las
with
propiedades
a
organolépticas se usaron orioles.
LNCS, and in order
Se
to
calculó una puntuación
maintain its
combinada de apetito a través de
chemical
escalas GAS
properties, we used
que se
columns.
obtuvieron durante los
And
días 1, 3 y
we
5
managed
y 2,
to
4 y
see
6
the
de
results between
intervención
days 3, 4,
que
and 5,
representaban el
and they
primero y
would
el último día de
represent
cada
the
una de las
first
tandas
and
de
last day
15
of
días de
each and every
repetición.
single round within 15 days
Entonces, en
of
el día 1 y
repetition.
14,
So from 1 day
aquí
to
se indican
14,
como días
as you
1 y
can see
3,
here, as from one day,
pasaron los
from
voluntarios
day
por
1
estos
to 3,
procedimientos,
here
los
they would go
mismos
through
en
these
el 3 y
procedures.
5 y en el 2,
The
4 y
same
6.
thing would happen
Estos
from
fueron
3
los
to 5,
mismos
and then
para
for
las bebidas, con la
46,
diferencia de que se
they
reunieron
all
una
shared the
dietista para
same
ajustar su
elements,
dieta
or
de
they were
forma que
similar at
la
least in their
incorporación de las
elements, and they
galletas
were
de 15 días no
incorporated into the
representa así un aumento
15-day
de
trial.
la ingesta de
However,
las
we saw
galletas
that
sobre
there
su
was
ingesta
no
normal.
increase that would be significant to their normal intake of food.
En cuanto a los resultados
Now,
principales,
regarding the main
la puntuación
findings,
combinada de apetito
composite
mostró que no
appetite
hubo
scores show
diferencias
that there
entre el
was no difference
comportamiento
between the behavior
en sensaciones de saciedad entre la sacarosa, la stevia RPM
between
y el neotamo, tanto
sucrose
valorado en
and
el periodo
stevia
temporal de 3
and
horas
neotame.
como en la
In the
gráfica
temporary profile of 3
mostrada
hours
por valores
and in the
negativos.
adjusted
Por
curve,
tanto, no se
we
puede
saw
considerar
no
que haya sido de hambre
significant changes.
rebote,
So we can
pero sí se
definitely say
pudo
that there
observar
are
un
no
impacto de
meaningful
lipoexposición,
aspects that we
de
need to
forma que entre los
consider.
primeros días de
There
los
was
14
no
y cada
impact
uno
on
de los
neotame or
periodos
RAB-M or
de ingesta
sucrose and
repetida,
appetite,
hubo
no
una
evidence of
mayor
rebound hunger with
insolubilidad
neotame or
del día
stevia,
1 que el
RAB-M or
14. Sin embargo,
sucrose, and
esto
overall
permite
impact
que
of
esa diferencia
exposure
era muy
day,
pequeña, como se
greater
puede
appetite
observar
suppression of
en las
ED,
gráficas
could not
biolíquidas a la
happen. You
derecha
can
de
actually see that in the graphs on the right of this
En cuanto a la
image.
respuesta
Now,
glucémica,
regarding
esta fue muy
glycemic
parecida
response, it
a
is
la
quite
respuesta
similar
de
to the
la
response
glucosa,
of
de las bebidas, tanto para
the
la glucosa como
beverages for
para la
both
insulina.
glucose and
Así,
insulin.
la stevia,
So
retinol y neotamo no
stevia,
subieron la cantidad de
sucrose, and
glucosa en
neotame
la
did
secreción
not
de insulina tanto
present
como la
spikes
sacarosa. En el caso
in
de la
the
insulina,
presence of
la
in the
diferencia fue
response, in the
significativa
glycemic
para
response,
ambos
and did not
edulcorantes,
show also
mientras
a
que el retraso
significant aspect
de
that
la
would be of
glucemia fue
concern
significativo para
either of the three. So insulin lower after neotame and ribosome compared to sucrose. In this case, no effective exposure at A was observed either. Now, regarding the safety parameter for both trials, we did not increase in hunger after any isolated or mixed. No change in food preferences is seen either, which I did not manage to prove in this presentation. Now, we did not see an impact in the blend, especially for metabolic markers, specifically for liver markers or those in blood. We did, however, show a few changes in the relative variables, but they were not clinically significant because they would go by less than 3% of the baseline levels. And we observed that only with certain blends, there was no impact of isolated LNCSs in blood after consumption of the cookies. Regarding GI symptoms and other events, we saw vomiting, belching, altered lower bowel opening frequency, and in the case of the cookies, we saw excess bloating or flatulence, especially after neotame, something that could have happened due to the presence of polys, which are lower digestibility carbohydrates. All of these effects, however, proven to be too deleterious so that the trial had to be abandoned or too serious. So our conclusion is this is the first coordinated study of its kind to investigate acute and repeated exposure to combined or novel LNCSs, whether in liquid or solid food matrices. Individuals with overweight and obesity, both forms of the LNCSs, improve the glycemic response, which can represent an additional benefit for diabetes prevention beyond calorie reduction. Novel LNCSs did not produce an adverse impact on appetite, metabolic, and health markers either, acutely or after 2-week repeated daily consumption, regardless of food matrix mode of delivery, which is very interesting for the design of other nutritional interventions. Combination of sweet foods with LNCSs can have beneficial effects on glycemia in matrices where the sugar reduction is technically feasible. However, in other matrices, the results might vary. Future research needs to be fixed on the impact in the long term of these new LNCSs on the control of chronic diseases, including their effects on gut health and food behaviors. To finish, I want to extend my gratitude to the members of the study for the logistics, for the scientific knowledge, and personally, I want to thank my colleagues for their cooperation. And that's all for me. Thank you very much.
Thank you, Eva. Please stick with us for the panel discussion to follow. So it's my pleasure to introduce the next talk I'm very excited about. It comes out of our lab, the Stop Sugars Now trial, effective replacing SSBs with LNCS beverages on gut microbiota and cardiometabolic risk. This is presented by Sabrina Ayoub-Charette, and I'll read you her bio. But the first thing to say, she's a former PhD student of mine who I'm incredibly proud of, who led this work and really, I think, suffered immensely through this trial, but managed to drag it through COVID and get the results to be able to present to you. So she did an incredible job. But she works in the Department of Nutritional Science at the University of Toronto. Her early work focused on systematic reviews and meta-analyses. More recently, she's interested in the shift towards the role of low and no-calorie sweeteners in replacing added sugars in the diet and their effects on cardiometabolic health through the human gut microbiome. Dr. Ayoub-Charette was the main data analyst. She led it, but she was also the main data analyst and bioinformatician of the Stop Sugars Now trial, and her expertise is in the lab protocols, causal inferences, evidence synthesis, and trial design and conduct. So she will also join us via Zoom. Sabrina, I guess once we bring you up, the floor is yours.
Thank you so much, John. Can everyone hear me? I'm assuming so. You guys will stop me if you can't. And thank you all for the organizers for having me join this session virtually, and I'm excited to present our Stop Sugars Now trial results. Here are my conflicts of interest.
Thank you. Oh. Just 1 second. We need to put the image in the screen here.
Okay.
I can see you in Zoom. Our people in Zoom can see you, but we are holding. Okay, we can see you now.
Great. Thank you.
We hear you and see you. Thank you very
Beautiful.
much.
And you see my slides as well?
Yeah, of
Okay,
course. Just
great.
1 second. We are holding to see you because now I can see you in Zoom, but not in the room. Just 1 second.
Okay.
Just 1 second, Sabrina. Sorry.
Thank you. Yeah, no problem.
One more second. We are waiting. Okay, now we are ready.
Beautiful. Thank you so much. So yeah, here are my conflicts of interest. I think all of the previous speakers before me have really highlighted the problem of sugar-sweetened beverages and them being a public health concern, as well as the standard of care of water being recommended, as well as the WHO recommendation to reduce free sugars to less than 10% of energy, with a conditional recommendation to reduce it to less than 5% of energy. But the intended replacement for sugar-sweetened beverages, so replacement that maintains the sweetness, the carbonation, and the flavor would be the non-nutritive sweetened beverages. And like Dr. Sievenpiper highlighted, there's quite a bit of discrepancy in the public health and clinical practice guidelines on the recommendations of non-nutritive sweeteners. As well as this is a very heterogeneous group of compounds. And as Dr. Romo-Romo mentioned, we can't look at them all together, but we have to split them up because they're such different compounds that have different effects, different movement throughout the body. Recently, there's been growing interest in the gut microbiota as a type of mechanism to explain the effect or the lack of effect of non-nutritive sweeteners on health. This really originated from this 2014 study that Dr. Romo-Romo very clearly described. There was some issues with the study, the small sample size, very high dose, as well as a lack of randomization, lack of control group, and this was primarily an animal study, but it was very informative in hypothesis generation and informed the future of this field. And since 2014, there's been quite a few studies that have been developed looking at the gut microbiota as a mechanism. Most of them do not find an effect of non-nutritive sweeteners on the gut microbiota. Some of them find some benefits on cardiometabolic outcomes, including lower adiposity, body weight, and hip circumference. And there's some studies here that show harm of non-nutritive sweeteners on the gut microbiota and cardiometabolic risk factors. But again, these studies have some issues in randomization that limits the causal inferences that can be drawn. And that's really where our perspective came into about. So until the SWEET trial, there was no trial that was developed looking at the intended use of non-nutritive sweetened beverages and non-nutritive sweeteners, which is to displace energy from sugar sweetened beverages used in common food sources. So not just capsules or sweeteners dissolved in water, but in the actual food sources that people are exposed to at the grocery store. There was also very few studies that were looking at non-nutritive sweetener blends, and we know that on the market, non-nutritive sweeteners are usually used in blends to kind of offset some of the undesirable flavors or characteristics of any one sweetener in particular. And most studies were not looking at the target population for non-nutritive sweetener use, which is people with overweight or obesity that are looking to mitigate their risk factors. And so in response to this, we designed the Stop Sugars Now trial to look at the best replacement for sugar sweetened beverages, non-nutritive sweetened beverages, or the intended substitution, versus water, or the standard of care substitution, on type 2 diabetes risk factors through changes in the gut microbiota, and specifically in the target population for non-nutritive sweetened beverage use. And we wanted to look at this pragmatically, directly comparing those three comparisons of public health importance. at real world doses using beverages that people are exposed to at the grocery store, sweetener blends that people are exposed to at the grocery store, and that also applies to the level of sweeteners or the percentage ADI that people would be typically exposed to when buying these drinks. And so our objective was to assess the effect of replacing sugar-sweetened beverages with these two comparators on our two primary outcomes, changes in plasma glucose incremental area under the curve and gut microbiota beta diversity between the interventions, and our 5 secondary outcomes, which support these primary outcomes over 4 weeks in overweight or obese participants. And this really allowed us to answer, like I said, those 3 comparisons of clinical and public health importance, the intended substitution with energy displacement, the standard of care substitution without energy displacement, and the reference substitution without energy displacement. And this really as well lets us to isolate the effect of energy versus sweeteners themselves. So the Stop Sugars Now trial is a CIHR-funded, randomized controlled crossover trials with 3 arms. Each phase was 4 weeks long, separated by a 4-week washout period. And our trial was registered on clinicaltrials.gov before we started. We included overweight or obese participants that are healthy, and they are consumers of sugar-sweetened beverages, specifically sugar-sweetened beverages with a non-nutritive sweetened beverage equivalent that is sweetened by acesulfame, potassium, and sucralose, and that was important for us for objective biomarkers of adherence. Here is what the trial looked like. So each phase was 4 weeks long. The 3 interventions were given in a random sequence order. And at the start and end of each phase, we took our outcome measurements as well as diet records and objective biomarker measurements in the urine and stool samples as well. So in Canada, these are the beverages that we have available to us at the grocery store. The glucose fructose here is our fancy word for high fructose corn syrup. In the non-nutritive sweetened beverage arms, you can see here that most of our non-nutritive sweetened beverages are sweetened by aspartame and acesulfame potassium at an ADI dose of around 3 to 4%. Some of them are a bit higher, like the sucralose here. But there's only one sugar-sweetened beverage in Canada sweetened by sucralose at the time of us running the study, and it was the Diet Orange Crush. And then during the water arm, we offered still or sparkling water. If a participant came into the trial and they're used to drinking 1 Coca-Cola per day, during the sugar-sweetened beverage phase, they would maintain that 1 Coca-Cola per day. During the non-nutritive sweetened beverage phase, they would switch their Coca-Cola for a Diet Coke or Coke Zero. And then during the water phase, they would do the sparkling water, still at 1 can per day. And that's a 355 volume. As I mentioned, we had 2 primary outcomes and 5 secondary outcomes and a whole host of exploratory outcomes, which I'll walk you through today. We also had our adherence outcomes, which we use self-reported adherence as well as those objective biomarkers in the urine that I was mentioning for acesulfame, potassium, sucralose, as well as sucrose and fructose. Our statistical analysis, our primary analysis was intention to treat using repeated measures, linear mixed models. We also used a Benjamini-Hochberg with parallel gatekeeping procedure to control for false discovery rate. And so here are the results. We had 80 participants randomized. In total, there were 66 people that finished the trial. So we had really good retention, over 80%. We had 52 participants included in the per protocol analysis, but all 80 participants were included in the intended to treat analysis. Here I'm showing baseline characteristics. So the first column here is all 80 participants, the completers, the per protocol, and then the dropouts. Most of the characteristics were pretty much the same in all 3 of these groups. So I'm just going to be talking about the first column here of all participants. We had an even split of males and females. All of our participants were overweight or obese using ethnic-specific cutoffs, leaning more towards the obese range of BMI, but their blood pressure and fasting glucose and 2-hour glucose were within normal ranges. Most of our participants were of European or mixed ancestry, had undergraduate degrees, and worked full-time. We also had some participants taking medications that indicated to us that they were at risk for cardiovascular disease, diabetes, etc. And I've listed them here. Most of our participants as well, or some of our participants, sorry, had some diagnoses of hypertension, hyperlipidemia, arrhythmia, and 41% of our participants met at least 3 metabolic syndrome criteria. So this is really the target population for non-nutritive sweetener use. Our favorite sugar-sweetened beverage at the start of the trial was Coca-Cola and Canada Dry Ginger Ale. The average dose was 2 cans per day of 355 ml, and the range was between 1 and 5. And during the non-nutritive sweetened beverage phase, that means that most people were consuming a blend of acesulfame, potassium, and aspartame, and only 5% of participants were consuming the sucralose-only beverage. Here's how I'll be showing our primary outcome. We have the intended substitution on this side of the triangle, the standard of care substitution at the bottom, and then the reference substitution here. And here are p-values that I'm showing you for the intention to treat, completers, and per protocol for both primary outcomes. And as we can see, the largest p-value was greater than our Benjamini-Hochberg critical value. And so the other primary outcome, in this case, the gut microbiota beta diversity, was tested against a critical value that was a bit lower. Both primary outcomes were non-significant. And so all of our secondary outcomes became exploratory outcomes to protect the false discovery rate. We also did a whole host of subgroup analyses, and none of them were significant. For our exploratory outcomes, I'll start with the intended substitution. We saw here a reduction in triglycerides in all 3 analyses, the intention to treat, completers, and per protocol, with additional benefits in the completers and per protocol on HDL cholesterol and waist circumference, respectively. When looking at the water standard of care substitution, we saw improvements in Matsuda, diastolic blood pressure, and triglycerides in all 3 analyses, with, again, additional benefits in the completers and per protocol analyses, where we saw improvements in HDL cholesterol and insulin response and secretion. And for the reference substitution, we saw no differences in any of these outcomes. I'm just realizing that this figure is not the correct figure, but the text here is correct. As for our dietary intake, we saw when sugar-sweetened beverages are being replaced by either the non-nutritive sweetened beverages or the water, there was a reduction in total sugars, free sugars, sugars from beverages, and carbs, and a proportional increase in fat and protein percentage of energy. And this isn't necessarily compensation with fat and protein, it's a signal of a total reduction in total energy. For adherence, we saw that people were doing what they were supposed to, either self-reported or objectively, which is always a good sign in a trial. And we saw no serious adverse events during the trial. There were some adverse events and some symptoms, but they were unrelated to the interventions. So in summary, here are the benefits that we saw. So when sugar-sweetened beverages are being replaced by either the non-nutritive sweetened beverages or the water, we saw some benefits as well as a consistent lack of harm, whether it's surrounding the gut microbiota beta diversity or these cardiometabolic outcomes. There's some hypothesized mechanisms here. I think for the sake of time, I'll skip it, but I'm happy to have more discussion about this in the Q&A. Our trial had several strengths and limitations, including our pragmatic design, really supposed to simulate what happens in the real world, as well as having these directly translatable results that are of clinical and public health importance. So finally, we saw that there's no adverse effects on glucose tolerance or gut microbiota diversity, with additional benefits depending on adherence to the intervention. Interventions were well tolerated, and we're confirming the lack of harm of non-nutritive sweeteners and non-nutritive sweetened beverages, and demonstrating the intended benefits when replacing sugar-sweetened beverages. And we're still supportive of the water as a standard of care, but it's that non-nutritive sweeteners and non-nutritive sweetened beverages may be a helpful strategy to get off the sugar-sweetened beverages. All of this work wouldn't have been possible without our great team of lab mates and collaborators and our funders, which I'm thankful for. Please reach out to me if you have any questions. And we're currently submitting this manuscript for publication, so please look out for that soon. Thank you.
Thank you, Sabrina. Stick with us if you can for the panel discussion. So we're going to move on to our next talk. We're going to hear more about the EU SWEET project, but also the SWITCH trial. So we're going to have, I think, a whistle-stop tour from Jason Halford, who will take us through both these really pivotal trials. looking at the effects of long-term LNCS consumption on weight management and health outcomes. And bio for Jason, who doesn't need a lot of introduction for many, but he's a professor, a psychologist and researcher specializing in appetite regulation, eating behavior, and obesity. His research addresses the biological and psychological factors that influence eating behavior, weight management, and obesity. His main areas include the study of mechanisms of appetite and satiety, the effects of advertising and marketing on children's eating habits, food insecurity and its impact on family health, and weight stigma. He has also participated in clinical trials focusing on strategies for weight management, the use of low, no-calorie sweeteners, and pharmacological treatments. He currently leads the European Sweet Consortium and the SWITCH study, both of which we're going to hear about, focused on metabolic health and obesity prevention. Jason. And Jason is very jet lagged, so we're going to try to all give him our energy and keep him awake. Come on in.
Thank you very much, and it's great to be here. My first time in Mexico. I'm looking at my translators who are busy changing over. Hi guys, I'm from the north of England, so I do talk very fast, so I'll try and slow down. But if I see you waving your arms desperately, I know I really am going too fast. Right, so I'm going to talk a little bit about the SWITCH study, which we've got the 12-week data and the 52-week data out, but I'm also going to show you the full 2-year data. Just switch the title over so I know what I'm talking about, but I thought it was useful to have it in both languages. And then I'm going to talk a little bit about the SWEET trial as well, which involved 4 of our leading labs within the SWEET consortium. So here are my conflicts of interest. I don't think any are related to the topic which I'm going to talk about. I don't take personal research money. Any monies that I earn through consultancy or other activities go to my university and pay for PhD students, so on and so forth. So first of all, I'm going to talk to you about the SWITCH trial. And the SWITCH was a randomized controlled trial of the effects of non-nutrient sweetened beverages during weight management. Okay, so this is purely focused on beverages, not foods. That's how it differs from the SWEET. And I was involved in this along with other members of my lab, and the actual protocol and the idea, the conception came from myself and Joe Harold. We worked on this for about 3 years, 8 years ago. That's how long the trial has taken, because we had to have cohorts of people coming through the trial. And of course, we had Brexit and COVID to deal with as well. COVID we could do nothing about. Brexit was a self-induced injury, but there you go. This was entirely based at the University of Liverpool, so it was a weight management intervention which was conducted in Liverpool. I just wanted to point that out as well. I'm not going to go through this rationale because I think everybody's talked about that, and I think many of you have given me an absolutely brilliant introduction. But the one point this trial was addressing was the fact that WHO suggested there wasn't long enough and large enough RCTs. It was reliant on observational evidence, and I think we've repeated that. So what we did is we took a study conducted by Peters and colleagues, and we expanded it. We expanded it and dealt with one of the problems with the study is they'd not randomized people's experience of drinks before they went into it. So we randomized people who are naive for non-nutritive beverages or the people who'd consume them. So we got rid of that confounding error. And what we did is we extended beyond the original 52 weeks to do a follow-up over 2 years. So we've got 2 years of data, around 450 people joined the study. We managed to keep about half of them in. Now, what did we have? We had healthy adults from the Merseyside area between the age of 18 to 65 years. Their BMI was living with overweight and living with obesity between 27 and 35. We could have actually taken it to 40 in hindsight. They had to be regular consumers of water or beverages on a daily basis. Obviously, because it's a weight management trial, we didn't recruit smokers or those who recently quit. We avoided people with specific conditions, food allergy, excessive alcohol intake, which is an issue in the northwest of England, seriously, because part of our weight management program addressed the issue of alcohol. Obviously, taking medications, which are known to affect appetite. If they're doing regular intense exercise, we couldn't take them either, because part of the program was exercise. And if they've been dieting or they changed their weight in a significant way in the past 6 months. The trial design was a parallel group open label controlled equivalence trial. So it's powered to detect whether equivalence rather than difference, okay? So it's detecting whether there is statistical equivalence. Participants were randomized based on their gender, their age, their BMI, and whether they were non-nutrient sweetener naive or not. And those distributed equally between the groups. There were 3 phases to this trial, okay? 12 weeks active weight loss program where they come once a week. And then there was 40 weeks assisted weight maintenance, followed by 52 weeks non-assisted maintenance. And that was voluntary, because when we initially tried to recruit people to the trial, 2 years was too long for them to commit. It really frightened them. It had a big impact on recruitment. So we made this extension voluntary, and then what actually happened was when people got to 1 year, they were quite happy carrying on with the second year. But it just showed that actually just changing that in recruitment made a big difference. Now, through all of this period, people consumed either water or a non-nutrient sweetened beverage twice a day. And we supplied that to them, to 400 people. So you can work out that's 2 times 7 per week, okay, for 2 years. So this is the only study I've ever been involved in which involved us having a warehouse, a delivery man, and a logistics manager. Okay, never have I done a study like this before. It was absolutely insane, but it worked. It was a good team. So they had to consume at least 2 of these beverages a day, attend a nutrition-led group. That was weekly for the weight loss phase, and then that was monthly for the weight maintenance phase. The topics were the usual things like eating out in public, reading food labels, how to shop, dealing with alcohol, exercise, the normal things which should be in a nutrition-led weight management program. We tried to increase their exercise, which was, the original PETA study was done in Colorado, and Colorado is warm and sunny and bright. We were in Liverpool, where whichever direction you walk, the wind and rain is blowing in your face. So we do a lot more indoor exercise. We do a lot more, and we also adapted it as well around alcohol use, and put in a session around alcohol use as well. I'm going to move straight on to the data. I've not given you the primary, secondary endpoints. I've not given you a lot of details that perhaps other people have in their presentations, just because I've got to talk about 2 studies. So what we found, and sorry this is a bit pale, is obviously during the first, is there a laser here? Yes, there is. Excellent. During the first 12 weeks, we can see rapid weight loss, which is consistent with a 12-week weight management program. And then when it was supported, we can see it plateau out. Now remember, we powered this for equivalence. Okay, so it's powered to see if water and NS non-nutrient sweetened beverages were similar, because the hypothesis were non-nutrient sweetened beverages would actually stimulate appetite, so wouldn't be as good as water. Well, at 12 weeks, oops, I've gone one slide too far. At 12 weeks, we found equivalence. So they were performing pretty similar, but when we took it out to 52 weeks, so they had 12 weeks of weight loss plus 40 weeks of weight maintenance supported, we actually found the weight loss was greater in the non-nutrient sweetened beverage condition by about 1.4 kilograms. That's just shy of the 1.5 kilograms, which would turn that statistical significance into something which was clinically significant. So it just failed the clinical significance threshold. What happened at end of 2 years? I've rather given this game away because I went to slide ahead there. What we found when people are not assisted, the final 52 weeks, they slowly begin to regain the weight. They're still getting the water delivered, they're still getting the non-nutrient sweetened beverage delivered of their choice, but what we see is they begin to regain weight, and that's normal in weight management. They've not regained all the weight they've lost. It's quite a slow creep, but it's creeping back up. But still, when we look at the 2 years together, there is still significant weight loss from baseline. It's 3.7 in water, it's 4.8 in non-nutrient sweetener condition on these beverages. Now, fortunately, that's no longer statistically significant. It's certainly not clinically significant, but what we clearly see is water is not superior to non-nutrient sweeteners. That's the important thing about the trial. That's the key finding. So what did we see? We also saw reductions in waist and hip circumference over the trial. We saw it at week 52, and that difference remained at week 104, i.e. the end of the 2 years as well. And there were a variety of other biomarkers that we looked at. We saw a slight reduction, we saw a slight increase in total HDL cholesterol in the NSS condition, although that's not clinically meaningful. We saw significant differences between water and NSS for HbA1c. I can never read that. Can't read that one. You know the measure. You know the measure I'm talking about. I've not got my glasses on, I can't read. It's been a long day. IDEXA, we did IDEXA in a subsection. We didn't do it in everybody, but we did it in a subgroup. And what we saw was fat mass, fat-free mass, and android and gynoid fat distribution significantly decreasing both groups. We saw a little increase in hunger at week 104. We didn't see that at week 52, but we saw that at week 104, slightly more in the NSS group. Sweetener consumption was significantly reduced by water, which it should be because they were using water rather than sweetened beverages. Sugar consumption was significantly reduced in both groups when we looked at the diet diaries because they were using water and NSS. So it was working. Sugar reduction was down. So what are the switch implications? Well, at the end of active weight management, there was significant weight loss, which occurred in both groups. It was greater in the non-nutrient sweetened group, but it just narrowly missed clinical significance. At 2 years, significant weight loss persisted in both groups, but there's no statistical difference between those groups. Importantly, in both groups, significant weight loss was associated with improved anthropometric and other health outcome measures. So you can use non-nutrient sweeteners in weight management. Now I'm going to move over to the sweet trial, and you can see we've moved logos, we've changed. I have obviously a penchant for green, and I also seem to have a penchant for naming studies with the letter S, which gets very confusing when you're doing talks about them. We also had a European grant before this called Satin, and there was a rule in my lab now there's going to be no more clinical trials or projects starting with the letter S. So this was the sweet trial. It was actually in 4 labs. It was led by Anna Reben, sorry. I thought there was a question. So it was led out of Copenhagen, Maastricht. There was a site in Spain, which you saw Eva from as well there. And also there was a site in Athens in Greece. So great variation across Europe. We didn't run it in our lab in the UK because we were running switch at the same time. And it would have been absolutely insane to do 2 clinical trials at the same time. Again, this study was conducted and was impacted by COVID. But despite that, we got some quite decent results. So this just shows the size of the SWEET project. 29 partners across all these countries. So it was a lot of coordination between us, and we're grateful to have Anna come and help us with that coordination, with Joe and I there as well. So what was the SWEET project? Well, the SWEET project was a variety of different studies, 6 work packages, but this is work package 3. And this was a 1-year, multi-centered, randomized control trial investigating the impact of sweeteners and sweetener enhancers on weight maintenance, gut microbiota, and cardiometabolic health. And the important thing to notice about this is it wasn't drinks, it was a whole diet approach, okay? So it's drinks, but it's also foods as well. The study participants were 341 adults who were either living with overweight or obesity. We did try and recruit children. We tried to recruit families. The European Commission were particularly keen on doing this. It proved to be particularly difficult, particularly because we were doing it through COVID as well. So there's lots of problems around that. So we're not going to report the childhood data in this study. What was the protocol? We had 2 months of low energy density diet to get them to lose weight, no difference between the 2 conditions, and then they were randomized to one of 2 groups. Both of them aimed to have a diet of less than 10% sugars, in line with WHO recommendations. Just one group was given advice on how to do this, whereas the others were given advice plus access to a range of products which sugar had been replaced using a variety of different sweetener and sweetener enhancers. So this is what the protocol looked like, and we can see the timeline here. And just to remind you, we didn't get to do the follow-up. Why didn't we get to do the follow-up? Well, we didn't get to do the follow-up because COVID had an impact on our timelines. And unfortunately, with European grants, Europe doesn't allow you to carry on your grant. So COVID or not, we had to explain them some. Really, it's very difficult bringing people into laboratories with all the different rules across Europe, but rules are rules with European grants, and so unfortunately we couldn't carry on the follow-up. I think I've said pretty much everything on this slide, but here are some of the exchanges. Now, you imagine doing exchanges in one country, it's a bit of a challenge. Doing exchanges in 4 countries with lots of different products in their product ranges is an absolute challenge, because you've got to sit there and go, because what people are eating in Athens is not what people are eating in Maastricht. And certainly what people are eating in Copenhagen bears very little resemblance to the north of Spain. So in each of these sites, what we did have to do is find examples of product categories, various product categories. Here are the drinks, and you can see that you've got the ones with sugar here, and here's the ones with sweetness. So what we do is we'd actually redirect one of the groups, our sweetener group, towards that. But here, obviously, we're using actual foods as well. So we're substituting foods with sugar, including savoury foods, which some of them have quite high levels of sugar, with equivalents with sweeteners. And again, we had to go and hunt for these in Greece, in Denmark, in the Netherlands, and in the north of Spain. I'll move straight on to the outcomes, and there's some animation here, which always confuses me. But what we saw was there was a significant interaction between condition and time, whereby there was a significant greater weight regain in the group which had just got the advice, whereas the weight loss was better maintained in the groups which were on sweeteners. So you can see you both lose weight here over the 2 months with the low-calorie diet, but when randomized to either just don't consume sugar or don't consume sugar and have some sweetened, non-nutritive sweetened or low-calorie sweetened foods, it's the ones with the low-calorie sweetened foods who seem to have reduced weight regain. Get rid of that. And here are the secondary outcomes. We can see actually improvements in pretty much all of the secondary outcomes associated with successful weight maintenance. I think only one is statistically greater, and that's hip circumference with a greater p-value here, but pretty much the same across all these markers. And what does this tell us? So what can we get out of this? Well, at 1 year, the group who were consuming the sugar-enhanced products maintained greater weight loss compared with the sugar group. Now, this was 1.6 kilograms. So it's not only statistically significant, it takes us above that 1.5 kilogram bar for clinically significant as well. So we can argue that this is a clinically significant difference between the two groups. The intake of sugar-rich products decreased in both groups, but more significantly in the sugar and sugar enhancers groups. So these products aided that reduction in sugar beyond the advice alone. So that had added value. So what do we conclude from this? Including drinks and foods with sweeteners and sweetener enhancers in a healthy ad libitum sugar-reduced diet improves 1 year weight maintenance, shifted gut microcomposition. I've not shown you that data due to time and the fact I'm not a microbiologist, in a positive manner, and did not adversely affect cardiometabolic health. So I'll just leave you with this. I put this into AI this afternoon. It says, what do these two trials tell us? Well, they tell us that the primary common findings of both projects demonstrate that non-nutritive sweeteners are a safe and effective dietary tool to support structured weight management. And both projects reject the challenge or the general caution about the use of non-nutritive sweeteners for use in weight control by providing evidence for the benefit without adverse events. So just finally, I'd like to thank the many people involved in the SWEET trial that I've just shown you. Here's the Sweet Consortium, and there were many more people involved in it than those individuals there. And thank you for your attention. I'm sorry I'm a bit tired and a bit barbly in my presentation. Thank you very much.
Thank you, Jason. Terrific. We're now at the last talk. So we're now going to hear from Kees de Graaf on the sweet tooth trial, effective long-term exposure to dietary sweetness on sweet taste, liking, and preference. And I'll give you a quick bio on Kees, who I think is well known to many of you. Kees de Graaf is an emeritus professor in sensory science and eating behavior, the Division of Human Nutrition and Health of Wageningen University. The Netherlands. De Graaf got his PhD in 1988 on the taste perception of mixtures of sweet tasting compounds. Since then, he worked on the meaning functional role of sensory signals such as taste, example sweetness, odor, and texture for eating nutrition behavior, the regulation of energy intake, and body weight. He is co-author on more than 330 papers, which are cited about 20,000 times. A large section deals with the sweetness perception, sweetness preferences, and the impact of sweetness on kilocalorie intake and nutritional status. The mission of his work is to make the healthy choice the happy choice. Kees.
Thank you, John. Indeed, my life is sweet. Overall, I would say the whole career is focused on sweetness. This is my first time in Mexico, I must say. I came here with my wife about 10 days ago. We spent some time on the beaches on the East Coast. The last section was we went to the city of Valladolid, and I had some amazing experience with sweetness there as well, which I actually did not like, because what was very funny is that we got with a dinner, you often get bread with butter, and normally the butter is fat and a bit salty, but in Valladolid the butter was actually very sweet. They introduced honey in the butter, which I was really surprised to eat that. And also, when we were served some potatoes, they also mixed it with honey, which I think is very odd. So I was really surprised by the sweetness of some of these dishes. But anyway, overall the food was very good, I must say. So I enjoyed the beans and the eggs, and really nice culinary experience, which I didn't have before. So I really enjoy Mexico. The sweet tooth trial, that's a trial which is actually the cherry on the pie of my whole career. It's about long-term effects of dietary sweetness exposure on sweetness preferences. Here are some of my disclosures, mainly to do with the funding of the trial. The trial is composed of what they will call in the Netherlands a public-private partnership, where you ask companies to support a trial which is already funded also by the government. So it's a combination of public and private funds. But the companies, they don't have much to say about the design of the trial. We had an independent steering committee for the trial, which was composed of people from different universities, including Jason was one of the chiefs of the steering committee, and Raben, and someone from the Dutch Diabetes Foundation, and someone from the Dutch Institute of Public Health. So they were more or less independent from the companies and advising on the design of the trial and the interpretation. Let me start with the background of the trial. There's a very consistent narrative in society, and when you are birthday parties and talk about presents for your children, when they go to school, when they have birthday, the argument is, well, if you present them with sweets, they are exposed to more sweets, and they will learn to like sweets. And because they are liking so much sweets, they will have increased sugar intake, and in the end, that will lead to obesity. So sugar has a sweet taste, but sweet taste is also part of the culprit of obesity because it stimulates energy intake. That's actually the narrative. And that narrative on sweetness is taken over by many public health organizations. Well, we discussed it already, but not only on low energy sweeteners, but also on sweetness as a sensation per se. So the WHO argues against sweetness, Pan American Health Organization, NHS, Canada's Food Guide. And what you see here on labels of Coca-Cola or PepsiCo with low energy sweeteners, you do see kind of black warning label that the product contains low energy sweeteners and it's not fit for children. So that also includes a kind of warning against the sweetness of low energy sweeteners. However, when you look at the actual evidence between exposure to sweetness and the liking for sweetness, there's virtually no evidence to support that. There's been quite some studies, short-term studies. We did a number of short-term studies ourselves where we actually, when we expose people to sweetness, when you expose people to sweetness, do they like it more? No, and the liking goes down. We did one study where we exposed people for 24 hours to only sweet products. People get sick of it because they want something else to taste than sweetness. Also, the relationship between sweetness exposure and body weight. So if you have the idea that sweetness promotes intake, you would expect that people with a higher sweetness intake would have a higher body weight. Well, there's actually no evidence to support that. That's also a very strong narrative, which I think started before I started with my PhD in the 1960s. They already had the argument that if you consume a lot of sweetness, you consume a lot of sugar and then you gain weight because sweetness stimulates energy intake. But both relations, they are not very clear. So the aim of the Sweet Tooth project was to study the long-term effects of sweetness exposure on sweetness preferences, but also on things like food craving, taste preferences, body weight, biomarkers for cardiovascular diseases, for diabetes and other markers. The study design is actually very simple. We did a power calculation to detect differences in the primary outcome measure, which was the optimal concentration of sugar or sweeteners in a particular product. And we had three groups, one regular group with a regular sweetness exposure, one group which had a high sweetness exposure, and one group which had a low sweetness exposure for 6 months. We had a baseline measurement and we also had a follow-up time of about 4 months, so the total study lasted about 1 year. We did quite some measures for good scientific practice. We submitted first a protocol to the Medical Ethical Committee, but it took about 1 year to convince the Ethics Committee to actually that we were allowed to run the trial, because they argued that in accordance with the narrative, if you expose people to a high sweet diet, they of course will gain weight and you will produce obesity, so that's unethical and you shouldn't be allowed to do that. And then we come with the evidence that there's no evidence, that all the studies, well, you argue and you argue, and finally they agreed that we would have a high sweetness arm in the trial. Of course, we registered the trial, we registered the data analysis in advance, and we also had a study monitor who came to visit us to control for all the procedures in the trial. The dietary interventions, we had a low sweetness exposure in line, I would say, with the WHO guidelines. People only ate fruit in that as a source of sweetness in the diet. No other sources of sweetness, so no sugar, no added sugars, no soft drinks, no jam on their bread, nothing, no cookies, no desserts, nothing. Quite boring, I would say. We had a regular sweetness exposure group, which is comparable to the normal Dutch diet, where people consume about 25 to 30% of their energy from sweet foods. And we had a high sweetness group in which people consumed about 40 to 45% of their energy from sweet foods. And there, that includes sweet desserts, sweet snacks, sweet spreads on bread, and other sweet stuff. You could think, well, these are very strange diets. Well, that's not true, because part of the Dutch population, when you compare it to the average Dutch National Food Consumption Survey, in each group there are quite a number of Dutch people who actually consume these diets, so these diets are not very unrealistic. We had a whole range of outcome measures. I won't go into detail to all of these, because then I will be talking until dinner, and that's what you don't want. I will focus on the sweetness preference, which is the primary outcome measure, and some biological markers related to obesity and diabetes. The results, the primary outcome measure is the change in preference score for sweet products. And we took a long time to actually develop this measure. This is when you do sensory science and you try to measure the optimal concentration of sweetness, what you need to do is to have a kind of range of products which go from very low sweetness to very high sweetness. And we know that for every product, for every sensory attribute, there's a kind of optimal concentration. Critics of also the UPF debate, they call that the bliss point. And the bliss point is that what food companies search to seduce consumers to the most liked product. And for saltiness, for sweetness, for bitterness, for sourness, but also for chocolate flavor or strawberry flavor, you have a kind of bliss point that people most like. What we did here, we searched for the bliss point or across the range of sweetness intensities, across a number of familiar foods and across a number of unfamiliar foods, that you would measure kind of generalized preference for sweetness across the whole food supply. It's quite difficult to do in order to get the concentrations right, that you get a really optimal concentration. This is actually also the main outcome of the trial. What you see here is the baseline measure for sweetness preference across the six foods, and for the three different groups. So, and this is what you also expect, of course, that the three groups at baseline, low, high, and middle, that they don't differ in optimal sweetness concentration. We didn't know what to expect, but if there were changes, you would see changes in the curves between the left and the right of this slide. But what you see is that the optimal concentration of sweetness, the preference for sweetness, stays the same for the low, for the middle, and the high sweetness group. This is actually one of the most interesting results, is also a measure of compliance. What you see here is the contribution of energy, contribution of sweet foods to the total energy intake across the 6 months of the trial, and also during follow-up of the trial for the three groups. And for the regular group, we see that it didn't change from baseline and didn't change after follow-up. For the high sweetness group, we aimed at 40 to 45 energy percentage of sweet foods, but they actually arrived at 28% of energy coming from sweet foods, which actually indicate that on average, this group had trouble of getting at the high sweetness level of the total diet. So it was not that they really liked the high sweet diet, but yeah, in some ways they was kind of resistant to get to the high sweetness level of the diet. The low sweetness group did arrive at their target level of 10 to 15 energy percentage of contribution of sweet tasting foods. And what is also interesting is that both the low and the high sweetness groups, they return to baseline levels after follow-up. So to me, that indicates that most people, they like a varied diet, which of course, we knew already for centuries, that people sometimes like a sweet food, sometimes like a savory foods, and you like to vary that across meals and across days and across months. So there's a kind of natural tendency to vary your diet in terms of foods and taste and nutrients, and that's the way it works. But it's also interesting that there's no effect of the sweetness of the diet on body weight. So a low sweetness diet does not lead to a lower body weight, and a high sweetness diet does not also lead to a higher body weight. So it's not true that high sweetness or sweetness does lead to a higher energy intake. It's simply not true. When you look at markers for cardiovascular disease, we didn't find any differences, but also in relation to diabetes, there were no differences with respect to glucose or insulin levels between the three groups. So to summarize, it's a bit of a boring study because we just don't find an effect. We did find an effect for differences in differences in sweetness preferences between the familiar and unfamiliar foods, in which the familiar foods were more liked than the unfamiliar foods. But otherwise, we did not find an effect in preferences. We also did not find an effect on perceived taste intensity, sweetness intensity. These remained constant. We did not observe any effects on energy intake. The proportion of sweet foods eaten across in test meals at the lab during the intervention did also not differ, and also no effects on markers for cardiovascular diseases or diabetes. So no effects. To summarize, neither a high or a low sweetness diet leads to changes in preferences for low or high sweetness foods. Subjects in the low and high sweetness group return to the baseline sweet food intake during follow-up, and sweet taste perception, food choices, energy intake were also not affected. And I think it's important to realize that exposure to sweet taste is not only pleasant, but also serves a very functional role in terms of intake and choice for nutrients and the whole energy intake for your diet. John, how far am I with time? Can I show a short movie? Yes, show okay. No, that's one of my favorite movies. It's I could show a lot of data, but this is actually PhD students who just started about 10 years ago, and he volunteered to eat 2 kilograms of grapes, one in the form of grape juice and one in the form of it doesn't work. Oh, that's a shame. Well, maybe I show it tomorrow morning at the start. It's yeah? Well, is it I tested it on my computer and it worked, but well. No. Well, otherwise I'll show it tomorrow.
Just 1 second.
Yeah, there it is.
Perfect.
Well, it's 2 kilograms of grapes with the same sugar. Yeah, everything is the same, of course. Fiber, sugar.
Okay.
Well, the message is clear. Texture, and Eva Almirón Roig was saying that, and also other people. There's a huge difference between solid and liquid foods in terms of taste exposure. And taste, of course, has a huge nutritional role. Taste signals nutrients. It's with salt, it's with sweet. And whether you ingest it in the form of beverages or in the form of solid foods like fruits, that's a huge difference. And we should take that into account. I think it's very simple. Simple, not so simple, but yeah. Well, there's a number of papers. By the way, the publication or the paper of this study has come out today in the American Journal of Clinical Nutrition, so that's nice. Yeah. And, well, thanks to all the people involved and also all the companies that are supported us in this endeavor, which took about 7 years. I think with Jason, you also, these trials, they cost an enormous amount of time and you present them in 10 minutes, but still, I think it's very valuable that we do these studies, and I hope that they help to rationalize public health recommendations for also sweetness and sugar and all the other stuff. Also, I hope the WHO will get convinced by the data. You cannot argue with the data, I think. Okay.
Thank you, Kees. Thanks to all our wonderful speakers. We'll invite to please come up and join us, including you, Kees, unless you need to escape for a moment. We're going to have a panel discussion scheduled for a half an hour. I think we're running a little bit behind, so I'll ask Maria will tell us what we're going to do.
Okay. Yeah. And Sabrina and Eva, I think they will join us.
Eva and Sabrina will join us. Okay, excellent. So hopefully there's enough chairs for everybody. We have 2 speakers that won't need chairs.
That's right.
Okay, well, we had really an excellent series of presentations, really giving us a nice download update on LNCS health effects with the new trial evidence. So I guess something I would ask, is does this trial evidence change anything in anyone's minds in terms of where we were? I mean, obviously we needed long-term data. There was a call for long-term data. You brought that forward with 2 of your trials, Jason. There's a call for effects of the microbiome. We saw some effects, obviously, with Alonso's work, some with the stop sugars, and then the context of all the existing work. Have we changed minds? Where are we? What's the state of the evidence, I guess I would put to our panel?
Well, with respect to sweetness, I think it's very clear that sweetness in itself does not promote energy intake. It does not lead to a shift in preference. There have been quite some studies, short-term studies on that. About 4 or 5 years ago, there was a study from the Monell group with a similar design, shorter. They also showed no effect on sweetness preference of a low sweetness diet or a regular sweetness diet. Recently, there was a study published in Scientific Reports a study done by PepsiCo, where they tried to lower the sugar concentration of sugar-sweetened beverages, but also diet-sweetened beverages. It was a big study, also 6 months, done in Mexico and in the US. They couldn't detect any, and they had 2 ways of reducing sweetness. One, a very strong direct way, going to about half the sweetness, and one in very steps, 6 months. But they didn't find an effect on the optimal sweetness concentration in soft drinks. It remained 10%. And yeah, and also there's recently they've done...
Which is where it is now, about 10% by weight, about 12,
yeah,
39 grams for about 355 mils, right?
Yeah, and if you look at the various countries, I looked at it in Germany, in Saudi Arabia, in Russia, in Turkmenistan, Mexico, it's everywhere the same. Recently, the Monell group, USDA, they did a trial similar to ours, but only with a low sweetness arm. They have yet to be published, the study, but they can come to the same result. So to me, this question is answered. We do not need more research on this. Maybe on low energy sweetness, but...
Well, we'll go through each panelist and they can, thanks, Kees. Lissette, do you want to comment? Maybe we'll go from left to right.
Bueno, yo considero que...
Well, I consider that at the end of the day, the conclusion would be not to take a radical decision. I also showed you the evidence on the other side of the metabolic effects that have been reported so far. Because at the end of the day, we have many conditions that we need to consider, many angles that we need to consider. In this group of substances, we said that there can be a number of components and many additives that we can have in the LNCSs and various methodologies for evaluation and assessment. So we need to accept, however, that there's evidence that shows that at the time that maybe they could provide something that might have not been considered beforehand. I do consider, however, that every organization that has published their recommendations will do so with the evidence that they have available at the time and what the meta-analysis proves. And although they have yet to detect the effects themselves, due to the methodologies that they use, because maybe an analysis in an accumulated fashion might happen or not, we need to consider that these angles can happen. We have yet to, even with my own talk, we have yet to take a position. I'm not telling you to not consume LNCSs, but I wanted to show you the evidence. I remember that in this other talk, there was an emphasis put into a person that goes to the consultation room and they don't consume any LNCSs for sugar. Well, for them, we would not recommend LNCSs, but it could be used as a strategy. Actually, the ADA, the American Diabetes Association, since 2018 changed the literature for LNCSs because they were labeled as substitutes for carbohydrates, and that is no longer the case. They are now labeled as a temporary measure that can be diminished through time. Specifically on diabetes population, which is different from the rest of the population, most of the studies don't happen for the people that with diabetes themselves, and this is why I think that the results will vary. At least in the result that I participated in, that showed specifically those changes. What happened is that these individuals had no possibility of compensating with a larger production of insulin to lower their glucose levels, because the insulin is supposed to be injected at the beginning before they eat, and it is related to the carbohydrate intake. So physiologically speaking, the healthy individuals and diabetes type 2 individuals, things are different. So this is why the recommendations need to be specific for certain populations, and at least we need to exclude few of those and have specific recommendations for diabetics, for people who don't suffer diabetes and or people who suffer other pathologies, because the behaviors will be different themselves. You can have insulinemia or whatever you can think of. So blanket statements are never good. And in a few particular cases, there can be an effect, of course, but we need to specify when we recommend something.
I'm not going to spend too long. It's my experience that these things take a bit of time to have an impact, and these studies have only just come out. By and large, having talked to WHO about the outcomes of sweets, they kept referring us back to their report. We're going, we know about your report. Here's some data which you find useful for your next report. So there is a little bit of resistance, but those two trials that we did showed that using non-nutritive sweeteners in the context of weight management was the same as in one water or just reducing your sugar advice. So we think in structured weight management, their approach. How we explain the observational studies, I don't know. Is it our job to explain the observational studies sometimes, I think? So I think that the data stands on its own to a certain degree, but it will take some time and there will be a great deal of resistance in some quarters.
Just going to go to the others and then I'll come back to you, Sabrina. And then Eva, Sabrina.
Thank you. I think I agree with everything that the previous speakers have said. I think there is a special attention as well to pragmatic trials, because it's one thing to show in a lab at a very high sweetener dose effects on the microbiome, for example. But if that's not what normal people are consuming every day, then how relevant is that, right? And I think with the SWEET project, the switch trial, I think we can really get more at that pragmatic level. That strengthens the evidence as well. And for the gut microbiome specifically, I think we have a lot of evidence showing no effect. And with the SWEET trial, the most recent microbiome data indicated that perhaps these are actually beneficial effects when you're replacing sugars with sweeteners. So I think the pragmatic evidence base is really strong at this point.
That's excellent. I think the sweeteners themselves often are as blends. So I think that's part of that isolation story in the pragmatic. The beverages are giving them as blends, and we need to test them as blends, not just different matrices. So Eva. You're unmuted. Go ahead.
Yes. Do you hear me?
We hear you.
Okay. Sorry, I wearing headphones. It's midnight in my home, so I don't speak very loud. Yes, very interesting, and I agree also with what's been said. I think an important issue here is to know how people behave in their day-to-day. In the WH report, is explained that in the cohort trials, people who consume the sweeteners may also consume sugary foods because in compensation, or they believe that, okay, I am allowed to have a bit more sugar because I already replaced my drink with a low-calorie one. So knowing what is the behavior of the people, and in these pragmatic trials is what we are trying to reach, I think is key here. I also wanted to notice that in our Work Package 2 acute trials, we use quite low doses of sweeteners. And we didn't present here. We also have data on yogurts, cereals, other foods. For some of them, we collected microbiota samples. We are still waiting to know the results, but I hope those also can provide some insight into this repeated exposure.
Excellent. Kees, you had one final comment you wanted to add, I think, to.
Well, yeah, well, maybe one comment is to, like you have the WHO advice and also the other advice of other committees on low energy sweetness. Of course, they do it with the idea that it's positive for health. But of course, the advice may also have adverse effects, I guess, for people. If you have at dinner parties or at evening birthday parties, they say, well, diet drinks are not good for you, but people still like to drink something sweet. I like to drink something with a taste. I get bored from water. And so if that is the reason that why people do not choose diet drinks or foods with low energy sweetness, but just use drinks with sugar, these advices have actually adverse effects compared to what they intend. And I never hear any discussions on these potential adverse effects that people should avoid low energy sweeteners. People just love sweetness and they want it. So you can deny it to people, but that doesn't solve the issue.
The unintended consequences, yeah, it's important. We'll go to the floor. Just kind of.
Bueno, tanto la obesidad como
Both
la
obesity and type 2 diabetes are inflammatory diseases of low grade. So, question would be, if sweeteners, those that are chronically consumed through time, are showing any changes in the microbiota. Because a theory that many studies have described is that in diabetes and obesity, there is a compromise of microbiota that might end up explaining the low grade of the disease. So my question would be, if the chronic intake of the LNCSs improves or worsens the inflammatory process of these types of diseases. As far as I know, there's no study of the LNCS effects in the microbiota of chronic patients. And in a few of the talks, it was mentioned that that is never studied in patients with diabetes or obesity. The studies tend to happen with healthy patients, and that is not the object or the key population. But I think I don't agree with that, because I believe we need to do these studies in which we can actually see whether there might be an impact of the sweeteners, something that would be more perceivable. In healthy populations, for instance, that don't eat LNCSs, the moment in which they start eating those LNCSs, we can actually see a change in their composition of the microbiota. Maybe we can think that due to the pathology in and of itself, there's some sort of dysbiosis. It won't be seen as an actual alteration, or maybe it could enhance it further because of the pathology itself. What we have seen in the studies, basically, for microbiota, well, they tend to happen only with healthy populations, at least as far as I know.
Sugars Now trial was an overweight obese, 40% had metabolic syndrome.
Yeah, I can only speak to it from the sweet study again, which was weight loss followed by successful weight management. And there we did see a change in my microbiota. It was judged as a beneficial change after repeated exposure. The repeated exposure would be about 10 months. Obviously, it's in a diet. It's a pragmatic diet. It's got lots of different sweeteners in lots of different products. But I think that's starting to indicate something in that sort of area.
Okay, we have another question from the floor. Hugo. Yeah.
En relación a este tema de la microbiota,
In relation to microbiota, I know it is very difficult to assess how consistent would be in terms of sucralose or saccharines. When we saw the first Swiss study, I know that there are many other studies that have yet to find that effect, especially for studies of larger magnitude of controlled agents. So for sucralose, how do you assess the consistency? I know that the methodology to assess insulin resistance might vary, and methodologies to evaluate microbiota tends to be quite variable, so it is hard to answer. And the other question would be, how clinically relevant would you feel that would be the use of added sugar that, of course, do create rather substantial changes in microbiota in favor weight gain and peaks of glucose. So the magnitude of that observed effect through very refined insulin resistance tests that allow it to be statistically significant would end up being translated into a clinical relevance. I know that we don't know that yet because this is something that happens in the long term, especially with prospective studies and comparisons in the long term. But I mean, the question is there, and I don't know if there's an answer for it, at least today. Well, regarding consistency, specifically with sucralose, it has proven to be more consistent in its effects in the clinical trials. No few that there are. I feel that we can analyze at the level of film. There's more changes in genus or species of like bacteria. We know that the plant has to be very large, at least for the bacteria. So we need to go into the different even clades of it all. In saccharine, however, it tends to be more variable in its effect. And you also need to observe the dosage. Several clinical trials have used very small doses. In our case, it was 30% of the IDA, which is translated into 270 milligrams of sucralose per day. And we show that, I mean, we know that the 100% of the ADA needs to be sweetened. However, there should be no expected effect, at least with 15 to 30%. And even though we would provide it with 100%, there should be no adverse effect, at least that we should consider. Now, in terms of translating that into the clinical aspect, I do believe it would be important because I don't have the response yet as to how we would have a minor or major effect in comparison with sugar. Maybe we might need to conduct a study that compares the individuals themselves with the outcomes themselves for both a caloric LNTS against a non-caloric LNTS. At least what I do believe in terms of insulin sensitivity, it does have clinical relevance because in the study of the Matsuda index that we see decrease by 23% of sensitivity to insulin. And with the other study, it went by about 40%. So, and that would be basically my answer to that.
Eva, online, you can unmute if you like, and then we'll go to another question.
Yes, I don't have an answer for this, but I can tell you that we have data that once we have analyzed, we may use for answering. We in the repeated exposure trial with the biscuits, we did a parallel one with yogurts and one with cereals, and we collected microbiota data. These foods contained a mixture of sucralose and ACK on one side, and then another set of the same food contained sucrose, and another set contained a stevia mixture. So we will be able, and these are crossover studies with the same participants. So we will be able to know in the same participant if there's been a microbiota change between the sucrose yogurt, the ACK and sucralose yogurt, and the stevia yogurt. So it's exposure for only 2 weeks, but it's a starting point. But unfortunately, we haven't analyzed this yet, so I don't know. but just to say that we will look into it.
Thanks, Eva. You'll also have the sucrose group, so I think that's important as, you know, in terms of the caloric and the glycemic sugar. To the floor. Sorry. Oh, so Engel, and then, okay, yeah.
Sí, solo quería comentar
I just wanted to comment on what Dr. Laviada pointed out. Truly, in the findings of this last study, from the very first study that we conducted in which we used about 15% of the IDA for sucrose, we saw a decrease of insulin sensitivity by using other methodology. And we found it a little unnerving. And perhaps we might do a clamp study, which is a standard methodology, very carefully so, about 30%. And instead of 15 days, we are going to give them that for an entire month, 30 days. And when I saw the decrease of the sensitivity percentage of R value, I became concerned, almost 40%. And then we started to compare with the results in literature, with our own study by using combined effect with the Matsuda index, and we saw that it coincided with the previous study and many others. So, and that's basically what it is. It is what it is. By using a rather purified methodology, if you will, in a very controlled environment and in individuals that did not eat any type of LNCS, they were very young too. So this, alongside microbiota, gave us some results. Now, regarding the clinical implications, all of the inflammation markers were there: PCR, 6-interleukin, TNF alpha, all went up. I know this is not clinically significant. These were healthy individuals with a normal PCR, up went to abnormal. At least statistically, it was significant for me. I don't know if physiologically speaking, it's telling us something, especially for lipopolysaccharides. It increased in individuals, and we also have a placebo group. And we were asking as to how variable these changes would be. Well, there was too much there. We were sure that microbiota is very changes if you eat a salad or if you're eating a cookie. And consider how we saw no changes of this stuff. We were checked on the methodology as well. I'm no expert in microbiota, but in our group, we did have one of them, and they answered all of the questions that were relevant. Now, consistency, repetition, purity of a sample, many details that were there and that were answered. It was a small study, but it was there. That's all I wanted to say. Anyway, thank you. I do want to mention a caveat and a few reflections. Well, first off, succinctly, to Eva, in the study that you did, specifically, study that you carried out in diabetic subjects, you see that there's an effective increase of glucose, but we also saw protein. It did not measure that directly because it was not part of the research. But like I said before, these were subjects that have good levels of blood sugar, and they were using LNCSs, and they actually had very good metabolic control, especially when you consider that as a good standard for diabetes. They're basically the stars of the diabetes control patients. And what we observed is that they would experience peaks because they were not controlling themselves, but at least in the long term, which would be the 2 hours after the fact, which is what the most of recommendations point out, the glycemia levels tended to be basically the same. So we are reaching a clinically good result. But something happens in the middle. That is those first 30 minutes in which we see the shift. Maybe it has to do with the production of GPA1, for instance, but we don't know so far. Well, it will be worthwhile measuring that because the interaction with flavor receptors can make it so that the gut cell might actually receive it. We know that the half-life of the cell in this case tends to be very short, but at least you need to measure it because whether it has clinically relevant effects, it is important to know the actual mechanism. This is actually our proposal for the mechanism that could have ended up happening, which was not measured at the time because we didn't have the resources, sadly. But that was the case.
So I've got a question for Dr. de Graaf. What is the current evidence related to the sweetness, early sweetness on infants, and the acceptance of all the aptitude to consume sweetened foods later on in life?
I can give a short answer. I can give a long answer. There's not much evidence right now. I know we've done ourselves in Wageningen studies on the development of sweet taste preference across age. And what you see is that newborns, so babies, just out of the womb, they prefer very, very high sweetness levels. They enjoyed it, they smile. If you give a 6-month-old baby fruit, you see a happy face because of the sweetness. That's not so nice to see, such enjoyment, such happiness. It's incredible. But sweetness preferences, the optimal sucrose level in drinks goes down with age until adulthood, and then it stays very similar. We've not done studies on exposure to sweetness per se, but we've done studies on fruits versus vegetables, where we gave babies, infants, well, they are people, of course, but half of the group we gave fruit as first foods, and the other half we gave vegetables as first foods. And of course, the fruits are very sweet and the vegetables are not sweet. And then we measured food intake and food choice and things like BM, body weight, and after 1 year and 2 years, and then we see no differences in food intakes or food choice across these babies. So I think there's still a need for these trials to be carried out. But so far, the evidence that sweetness in infancy or sweetness exposure in infancy affects sweetness preferences later on is yeah.
So thank you. And the last comment is regarding the microbiota and the sweeteners. Of course, every food, every diet is changing the microbiota relatively rapidly. So there is a second aspect, is that depending on the methodology that we use for evaluating the microbiota, so you can obtain different results. Of course, the methodology is increasingly going up, and we are able now even to detect strains for a single species, and this was unknown this methodology 3 years ago. Was not the case. But that I would like to comment is that I fully agree that regarding microbiota, we need to identify what sweetener, what low-calorie sweetener we are talking about. Because, for example, sucralose is not absorbed at all. So almost 100% is going to the colon. However, for example, aspartame is immediately degraded into amino acid. Amino acids are really absorbed in the small intestine. So no way to identify what are the changes in microbiota for a product that is really absorbed in the small intestine. Or the same for neotame or neotame or advantame. However, for others it might be, but this should be really very controlled, because if you do not control the rest of the diet, you can have biases. And I think that is clearly a new sign that we should do studies within the standard way of life. So I would like to do study, for example, putting, using, for example, sucralose, that's correct. But at the other side, we should use people having sucrose. And what is the matter? Maybe if you increase sucrose or you increase another sugar, you will also have differences in the microbiota. I think that we need further studies to identify this. And of course, step by step, and evaluating single sweeteners. Otherwise, we can obtain a lot of results with no sense.
Sí, claro, justo se recalca esto, ¿no? Que no podemos
This is pointed out actually that we cannot generalize the results until we get to all this as to how they metabolize and substances in the body. Sucralose and saccharine and stevia have been reported as well, because stevia is not being metabolized by the enzymes of the digestive tract, by some of the genuses of the microbiota. So we need to individualize that, and in the study that we carried out on diet, we ourselves controlled lifestyle in terms of the individual not changing their eating habits, because when in the study I would give them maybe a change in their lifestyle, I would modify those habits, and that would make no sense. This is why we decided to keep their own lifestyle, so that these factors that would have an influence on the microbiota would not be affected. And like Dr. Almeida pointed out, this is why we had a control group that showed no significant changes in the microbiota composition of the GI tract. And like Dr. Almeida pointed out as well, it was an environment that was highly controlled. You cannot extrapolate that to the rest of the population. But these, however, are findings that open up a panoply of hypotheses.
Terrific. I think Sabrina's probably got a comment related to microbiota still, so then, and Rebecca will get the last word. I just want to say too, I think the strength of your design, because it's randomized, those prognostic factors such as dietary change are randomly allocated. Any change is an effect of the intervention, which is also important to know, because if it's engendering changes and that's affected the microbiome, we should know that too. But I think we need more data. And I mean, we had some sucralose data. I'm not sure if that's what, only one person I think that Sabrina's going to talk about. But Sabrina, go ahead.
We had, I think it was 2 or 3 people consuming the sucralose beverage, but I was going to mention something that is important as well as the behavior clustering, right? So there's been some evidence that high sugar diets affect the microbiome as well. But if we think about it critically, like sugars don't reach the colon in a meaningful amount unless you're really taking a huge bolus of fructose and glucose at the same time. And so I think a lot of what we need to consider as well is not only sugar and sweetener, but like you said, the entire diet, and people who consume sugars or people who consume sweeteners, what is the rest of their behaviors that could lead to changes in the microbiota or benefits in the microbiota.
Excellent, thank you. And I'm going to give Rebecca the last word, although there may be some responses. Go ahead, Rebecca.
I do have a question. One is for the diabetic study. My question is, the stevia and sucralose that you used, were they pure or were they byproducts, commercial products, perhaps?
Eran productos comerciales que se venden en gotitas, que
These
se
are
añadían
natural
como
products that we find
líquidos
in
que venía el
Chile
desayuno.
in
Si el
little
desayuno
drops
tenía un
that you
jugo,
would add normally, for
era
instance, for your
jugo
breakfast.
100%
We would
naranja
include juice
exprimido
that was
y una
100%
leche,
natural,
era
for orange
leche
juice.
natural entera. Y lo que hicimos fue añadir el edulcorante repartido en ambas cosas para que no quedara tan dulce de una en los líquidos.
Gracias. Sí, más que nada la pregunta era por si había que considerar en el control el acarreador del producto comercial.
Ya.
Y bueno, en el caso del estudio, se hizo en cápsulas.
So I study you did in capsules. Something that was important is to consider exposure, real exposure, because the equivalent of 30% of IDA in sweetness is hundreds of kilos in sugar. So this direct exposure that was acute, maybe that would not be translatable into real exposure for the regular patient. So other than that, did you manage to interpret the bypass of the sweet flavor receptors in the mouth? Because you were directly going into the gut and how that ended up impacting the changes that you observed. Actually, we did the capsules part because it is hard through a food matrix to reach this specific dosage. However, it was divided in 3 doses. Those 270 milligrams were divided in 3 capsules of 90 milligrams that they took 10 minutes before dinner, 10 minutes before their meal, and 10 minutes before the breakfast. So we wanted to sort of skip the stimulation aspect of it all for the oral cavity receptors in order to see and measure directly the mechanism through going directly into the gut. So the doses was divided, but we did that with this intent in mind so that it would not go through the products themselves and go directly into the GI tract.
Terrific. The only other thing I would just mention around this trial, which I found interesting, is your placebo were cornstarch. Was it raw cornstarch? And we know if we give that as a preload, it lowers the glycemic response and insulin response to meals. This is well documented as a second meal effect.
Fueron 270 miligramos, menos de medio gramo.
Milligram, less than a milligram.
Okay, I was going to ask you how much. Okay. Yeah, interesting, because you always worry about a control being maybe...
Sí, fue la misma cantidad de...
Yes, it was the same amount of sucralose as well, milligrams.
Interesting finding. I think we need more research, certainly, I agree. Terrific. Thank you, everybody. We get some housekeeping notes, I think, from you.
Tenemos algunos avisos parroquiales. Before I was going to close the session today, I want to thank you all and the experts for joining us today. It's been quite enriching day. I believe we have all learned from one another. And those of you who are online through streaming, I also want to thank you for bearing with us today. And with this, we conclude the session for the day. The experts will, however, continue to work tomorrow. For those of you on Zoom, you will be given information on your participatory certifications so that you can get them electronically. These instructions you will receive online via email. Well, we are finally over with this day. I think we want to thank you for your presence and for your knowledge once again.